Representative Connolly, welcome.
Okay, we're live on YouTube.
Super. Well, good morning, everybody. This is the Joint Interim Labor, Health, and Social Services Committee for the Wyoming Legislature. Today we are having a purely educational session. We are not acting on any bills. We are not going to take any actions. So we are going to educate ourselves and hopefully some other folks. I have received some interest from other legislators to whom I sent the information. So hopefully we'll manage to educate a lot of folks. Donna, would you call the roll, please?
Chairman, I believe that Katie is calling the roll.
Oh, okay, Katie. Sorry. Katie, are you there? You're muted. Katie, if you're talking, we can't hear you still.
Seems like Katie's having some audio troubles. I'll go ahead and call roll.
Thank you.
Senator Bouchard.
Excused.
Senator Furphy.
Excused.
Senator Hutchings.
Excused.
Senator McCowan.
Excused.
Representative Clifford.
Excused.
Representative Connolly.
I see her.
Yeah, I
We're
see
talking.
Representative Connolly in the meeting. Her audio must be having some issues currently. She appears to be unmuted as well. Representative Flintner.
Here.
Representative Hallinan.
Here.
Representative Ottman.
Here.
Representative Romero Martinez.
Excused.
Representative Stivar.
Present.
Representative Worf.
Excused.
Chairman Baldwin.
Here.
Chairman Wilson.
Here.
Madam Chair, can you hear me now?
We can. Thank you.
Great, thank you. And just so that you know, Representative Clifford had registered to testify rather than be a member, so she's trying to get back in.
Okay. Well,
Thank you.
Katie or Donna, if you'll just keep an eye out for her and let her in. And keep an eye out for any other folks that may seem to be wandering in the cloud trying to get in. I guess we've all forgot how to do it since March. Dumped our brain. Senator Baldwin, I wish I'll make a small chastisement of the Senate for having such poor attendance.
Well, being the only one here, I'll take the lashings for that. I don't know where everybody's at.
Maybe we'll assign them a project. You know, that's what usually happens when you don't show up for something.
We could call them subcommittee chairs and that'll get their attention. I see a
Ask
yellow
them to
hand already up.
present the information. Representative Stivar, you have your hand up. You want to get rid of it? let's see. Lower hand. There we go. Okay. All right, committee. LSO, I'm sure Franz probably is going to, or whoever is from Department of Health can open us up. So on the agenda, committee, we have the Medicaid overview and Title 25 this morning. And my intention, just to make sure that we go on smoothly, you know how it happens is that you ask a question and then 3 slides later, your question was answered. So what I would like to do is ask you to just write down your questions. And then for the Medicaid one, when we have gone through the Medicaid overview, but before we start the DD component, I'll accept questions from the attendees. And then we'll take questions again at the end of the whole Medicaid presentation. But I just, and you know, you might say, mark, when you mark it down, say slide 3 or something, if that's where your question was, so that it makes it easier for Department of Health to go back. But I just think it'll flow a little bit better that way. I'm hoping that, well, hopefully it'll be all informative and we'll know more than we ever did. And I really do want to appreciate Department of Health. They've obviously gone to a lot of work to put this all together. Those of us who are on the committee or other legislators who are listening in, the goal was to have them set up some sort of PowerPoints that you can, you know, download the material and save later for reading over later, or presenting if you've got, you know, some sort of local community panel and you want to show some information. So hopefully these topics, which are large topics across the state, will be useful to those beyond just those of us here. So that's
Madam
all I
Chairman?
have to, Chairman Baldwin.
I just want to throw one other thing in. I would ask the committee members, while you're in listening to the meeting, to do us the courtesy of the presenters of keeping your camera live rather than changing it to a picture, so they know you're really here and really listening, and they don't just put up your picture because you could be off fishing or doing whatever. So just for a courtesy to the presenters, we'd appreciate that. No, Representative Stivar, you can't go fishing today. Thank you, Madam Chairman.
All right. Very good. Franz, are you the lead man on this?
Good morning, Madam Chairman. Good morning, Mr. Co-Chairman Baldwin. My name is Franz Fuchs, Policy Office, Department of Health. We actually have, going to start off with our Director Michael Tobias in the back here. So let's do a brief overview of the department, and then we'll kind of get into the one-on-one. That's okay. But I'm going to start sharing my screen. Katie, if you wouldn't mind turning that on so we can start presenting some slides. Looks like it's disabled. Yeah, still disabled. I guess we could just.
That's right. You know, we can, if just minimize your Zoom screen and put up the document that was sent to us, or you can access it off of the web, off of the committee website. It's on there.
Okay.
So we can, you know, you can, that way we can watch. We should be capable of doing 2 different pages up on our computers by now.
Chairwoman Wilson, this is Michael Tobias. I'm Director of the Department of Health. And I'm going to make sure that we have a quick chance to introduce everybody that's here so that you'll know who's in the room with us. So if we could start.
Welcome, Director.
Thanks.
Good morning, Madam Chairman, Chairman Baldwin. Lee Grossman. I serve as the Administrator of Home and Community-Based Services with the Division of Healthcare Financing.
Good morning, I'm Cherry Green. I'm with the Division of Healthcare Financing as the Senior Administrator, and we have oversight of the Medicaid and Kid Care CHIP program.
Good morning, Madam Chairman. Again, my name is Franz Fuchs, Policy Analyst, Director's Office.
Madam Chairman, members of the committee, good morning. Stephen Johansson, Deputy Director of the Department of Health.
And again, Madam Chairwoman, this is a presentation that has been done in the past and certainly has been updated. What I would want to tell you, and it's something that Chairman Baldwin has already heard, we are not, my first foray into the legislature was in '95 as a lobbyist, and I had a completely different role. So what I want to tell you is our job here isn't to sell or take positions with you on policy decisions that you should make. But what I really am proud of is the team that I inherited. So just a luck of mine that we have folks that are really good in data analysis, in understanding how systems work, particularly with our Medicaid system. I know Terry is tired of me saying she's the longest serving chair, and she looks at me like, don't do that to me, but she has great experience in this. And so what I really hope today that you understand is we're here to answer your questions. If there's information that we don't present, we're glad to do that. In terms of policy, that's just not our role here. So that's what I wanted to kick off with. We are going today to just do an overview of the Department of Health Operations, a quick review of our divisions, our 4 divisions, our aging, our public health, our behavioral health, and our healthcare financing, which is where Medicaid happens. We do have 5 facilities, again, that certainly you all know about, and it's where the bulk of our employees are today, and a lot of our direct care work goes on, although that's not the only place, because we also have in public health, both through the WIC program and through our public health nurses, folks that are out there directly providing services. And then we have finally just a description of the 5 general areas, programs. We've said it before, but it has impact on me since I was told the first time, 91% of our budget comes really in 5 areas that we spend. And so again, understanding that, I think helps to understand where we are when we're focusing, when we were looking at budgets, and when we had to go through budget cuts. You just couldn't do a 13% cut if you don't touch these areas. So it's another place just to help you understand where we have that kind of focus just from the size of our budget. So with that, I really think the time, Franz, you're going to take over the presentation and walk through it. So
Sure.
We're ready to go.
All right. Thanks, Director.
If I could interrupt for a minute, Madam Chairman and Chairman Baldwin, I did enable screen share, so Katie should be able to share the Department of Health slides.
Okay. Madam Chair, members of the committee, can you see the slides that we're sharing right now?
Looks great, Franz.
Those to our smiling faces. This may be slightly more informative than staring at a conference room. So we'll just kick off this Medicaid 101, talking about the difference between Medicaid and Medicare. So Medicaid obviously is not Medicare. Both Medicare and Medicaid are similar in some regards. They both pay for medical services. And in Wyoming specifically, they both really pay for those services on a fee-for-service basis. So that means essentially a physician will render a service to a patient, submit a bill specifically for that service to either Medicaid or in the case of Medicare, their administrative contractor, and then they get reimbursed specifically for that service. So it's very granular kind of methodology for payment. And that's consistent across both Medicare and Medicaid in this state. In many other states, there's a lot more managed care in both Medicare and Medicaid, and so there's potentially less fee for service. But that's really how it's done here. Both Medicare and Medicaid are kind of a form of social insurance. And by that, I mean, one, they kind of spread risk across the population, but it's really subsidized by the public generally. So as you all know, Medicaid members don't, there's very little cost sharing, there's no premiums and so on. It really comes from general revenues. Medicare is much the same way. While there are payroll taxes, there are beneficiary premiums. There still is a lot of general revenue and general tax revenue that goes into Medicare as well. So really, they're publicly operated and publicly subsidized programs. They're both overseen by CMS, the Centers for Medicare and Medicaid Services, and of course they have a similar sounding name. But the differences really kind of end there. And I think the biggest difference, at least one of the biggest differences, is that Medicare is entirely federal. So the state has very, very little ability to influence Medicare payment policies or Medicare policies generally. whereas Medicaid is a joint federal and state partnership. So Medicaid is really, we have a lot of latitude within certain guidelines or guide rails to operate the state Medicaid program with this joint partnership. Medicare, I think the real fundamental difference, though, is sort of this difference in history and focus. So the idea of Medicare is really recent. It's coming from the 50s and 60s, and it really, was formalized in 65, but kind of the genesis of it was back in the 40s and 50s when medical care was really becoming more useful. In the 19th century, there were actually more doctors per capita than there are now, but they were mostly quacks. And there was a huge reform effort in 1910 with this guy named Abraham Flexner, who went around and surveyed medical schools and had this damning report about how terrible they were. And they really weeded out a lot of the quackery between 1910 and 1935. So doctors became a lot more useful on actually curing disease, just relatively recently. There's, of course, also scientific advances in antibiotics and public health that really made medical science, truly useful. And so at that time, it became more of a useful good. People started buying more of it in a sense, and health insurance really began to mature. And health insurance, again, is a really relatively new phenomenon. Starting in the 30s with the Blue Cross Blue Shield entities, it really grew, during World War II, when employers essentially started sponsoring these health insurance plans as a benefit to try to attract workers because wages had been frozen during World War II due to the War Labor Board freezes. So it sort of became as a way to attract employees. But what happened was, you have health insurance, you have the growing cost of medical care, which is increasingly useful. By the 1950s, approximately half of older adults were basically uninsurable. They could not afford health insurance simply because, as one gets older, one has more health problems, requires more medical care, and so the premiums, if you were to strictly underwrite people based on their health conditions, for many older Americans, it was completely out of reach. And so that's really the genesis of Medicare, was really trying to provide health insurance for older Americans while simultaneously preserving kind of almost like if you pull out the older Americans from the health insurance pool, it becomes more affordable on a community basis for everyone else. So that was kind of really the idea of Medicare. Today, it really has four main programs, and these have evolved over time. So it really started with Part A, which was this hospital insurance, mandatory for all Medicare members. Part A covers a lot of expenses, 80% of hospital-related expenses, but that 20% that's left is really to the member, and can be a really significant risk. I mean, 20% may be lower than 100%, but when you're talking about $100,000 bills or $1 million bills, it can be quite a risk for people. So a lot of people buy what are called Medigap policies to kind of cover that out-of-pocket risk from that last 20%. And then over time, they've added Part B, which is sort of optional physician office visit insurance. That covers, when you go to your doctor's office. That's generally fee-for-service in Wyoming. And then relatively recently, Part D, which was an optional drug benefit established during the W. Bush administration in 2006. And then Part C, I think, was in the 80s. This basically combines Part A and B and sometimes Part D into a managed care product offered by an insurer. So Medicare will pay the insurer sort of a risk-adjusted premium to cover certain enrolled beneficiaries, but then those insurers like Blue Cross, Humana, there's a bunch of other Part C, Kaiser in Colorado, they basically offer almost like an insurance product to seniors, and that can offer a variety of different benefits outside of the traditional Medicare Part B, like dental, vision, so forth and so on. But at the end of the day, they're kind of at risk for the Medicare population there. But the penetration for Medicare Advantage is very low in Wyoming. I think it's maybe 5% at most of Medicare members are enrolled in an Advantage plan. So it's really, in Wyoming, we're really dealing with A, B, and D, sort of this traditional Medicare fee-for-service. Medicare cost the nation approximately $800 billion in total spending in 2019. And I think it's important to know that Medicare is not like sort of a savings plan, like we put into Medicare and we're sort of drawing down what we put in when we were working. It really is pay as you go. So current taxpayers are paying for the current medical expenses of current Medicare members. And as you can see the breakdown there of what percent of total funding is from taxes, payroll taxes, the FICA taxes that we all pay, beneficiary premiums, and then federal general revenues, which come from income taxes and debt, obviously. There's also a small portion that comes from state payments. And you'll see that if you have questions in our budget about like what the the Medicare buy-in premiums or the Part D payments that we have to make, those are kind of part of those state payments that make a very small fraction of the Medicare expenditures. It's really also important to note that because it's really a medical focus, Medicare covers a small amount of long-term care, but it's really limited. And a lot of Americans are under the impression that Medicare will take care of them if they have to go to a nursing home. And that's true to some degree if you have a very limited stay. So if you're looking at a discharge from a hospital, you have approximately 100-day stay that will be paid for by Medicare, specifically for rehabilitative purposes. There's also a very limited hospice benefit. If your doctor can demonstrate that you're terminally ill, Medicare will pay for that. But generally speaking, Medicare does not pay for long-term care. And that's something that's, I think, underappreciated. Medicaid, by contrast, is it really this joint federal state social insurance program that pays for both medical care and long-term care of certain categories of low-income and medically needy individuals and families. And we'll kind of get into what the eligibility component there means later and what the benefits are. But there's a real strong distinction here with respect to the history of Medicaid, in that Medicaid has this really a much deeper, I think, deeper roots in social policy than does Medicare. So this is a picture of the infamous Tewksbury Almshouse in Massachusetts. This was an almshouse that was renowned for. There was a really scathing report that was done on the conditions inside. But almshouses and poorhouses are kind of the original way that this country and our roots in England have treated the very, very poor. So really these roots are kind of in the welfare functions. It's not so much on the medical side. It's really this sort of poor relief function that Medicaid has a very, very deep history. And again, it's not a new function. So I'm kind of pointing out this kind of history lesson here. But I mean, we have this first recorded almshouse by the first king of England, Ethelstan, in 936, when he first unified England. They established the first recorded almshouse in York. And then later on, those poor laws developed in England. They originally focused on sort of criminalizing begging that wasn't done by people who were appropriately poor, I guess. The people that were maybe idle poor or people that were able-bodied. So they basically would license beggars. To basically, you had to demonstrate that you had a condition that required you to panhandle, and then anyone else who was begging would be considered a vagabond, and there were really severe punishments for punishing them. And they kind of evolved in the 1600s to the Elizabethan Poor Laws, which really formed the basis for what was imported into the colonies of the United States. And that was kind of moving a little bit away from punishment, more towards sort of a correctional approach towards the poor. So. Again, these were sort of important to the colonies, or foundation of early American social services. And I think we're kind of going to go through a couple slides here. I'll kind of go through them quickly, but I want to point out that, the care settings that we know today, along with Medicaid, have roots going all the way back to this time period. So the nursing homes that today in all these counties really are their ancestors were the poorhouses. And so, things have changed today. Things are more specialized. They're more humane, and the costs have really shifted from counties and cities more to states, and then again to federal government level. But Medicaid is really sort of the current payer for this kind of care. But this kind of care has been going on for a long time. I think that's the main point we're trying to make. And so you'll see here on the left, we sort of divided up various categories of people. And this is a gross oversimplification of reality, obviously. But this is kind of how the Elizabethan Poor Law saw various categories of people back in the 1600s. There were the low income who refused to work, and the people with mental illness. So they often couldn't tell the difference because there wasn't obviously psychiatry or psychology back then. And they were termed the idle poor, people that in theory could work but chose not to. And then there were the able-bodied poor who were deserving. These were unemployed people, orphans or foundlings. And then you have, today we'd call them chins, children in need of supervision or juvenile delinquents. And then finally, the last category is what they call the impotent poor, or the poor who weren't able-bodied, they couldn't help themselves, and were truly, in this case, in their framework, deserving of aid. And these were people with physical disabilities, the frail and indigent elderly, and people with intellectual disabilities. And of course, they didn't really have these gradations of categories back then. That's kind of how they saw the world. But there is this kind of framework of the deserving versus the undeserving poor has really continued up to the current day, and I think you see it kind of in the discussion about Medicaid expansion to some degree. And then on the right, you see kind of the settings that these people were served in or abused, rather, in many cases. So, for example, low-income people who refused to work and people with mental illness were often just sent to jail. The unemployed were sent to workhouses where they basically would break large rocks into smaller rocks, do kind of menial labor in exchange for a bed and food. Orphans and kids would often be sent into indentured servitude among families, kind of a similar but to the workhouse, but sort of on a smaller scale. And then everybody else was put into these almshouses or poorhouse. And so the poorhouses really were the catch-all for anyone from the elderly to kids to people with disabilities to people with intellectual disabilities. We're all sort of crammed into these, pretty bad living conditions. But generally, these were operated by the counties and were designed to serve sort of the impotent poor. Now, things changed in the 1800s to 1900s. So there, again, that Tewksbury almshouse, there was a pretty damning report that came out in the late 19th century. There was this movement called the asylum movement, where people were exposing the abuses of the poorhouse system. And so states became much more involved in sort of these centralized building what were called asylums, right? And so the state hospital in Wyoming is a perfect example of what came out of that movement. And they were called asylums at the time. Today they're psychiatric hospitals. But at the same time, as we had for people with mental illness, coming out of not being still being put into jail to some degree, but now they're being moved out of the poorhouses and put into insane asylums back in the 1800s. Unemployed, still going to workhouses. They started developing poor farms. We have some of those remnants today, like the Honor Farm, I think, was a remnant of, as well as the state training school. Training schools were developed for people with intellectual disabilities. So these new kind of purple institutions here were really kind of state level, moving from the county level to the state level. But more specialized, more humane in many regards, but still subject to a lot of the same kind of abuse that happened in sort of the poorhouse. And the poorhouses were still around. So the county still had poorhouses. Wyoming had poorhouses, when it was a territory and when it was a state. Now, again, I mean, as things changed, in the 1900s, 1950s, now we're at slide 17, insane asylums now became psychiatric hospitals, but it's essentially a very similar concept. Reform schools were developed for chins and juvenile delinquents. The most important development here, though, was the poorhouses really kind of turned into what were called rest homes or convalescent homes. And especially during the sort of post-Great Depression, World War II era, the poorhouses really sort of were eliminated and turned into these rest homes, and mostly meant for, again, not necessarily kids or people with mental illness, but the only people that were really left in these were people with physical disabilities and the indigent, frail, elderly, were the last people to kind of be removed from these poorhouses. And then finally today, we have sort of these institutions that we know, or there's a lot of kind of acronym soup here, which we'll kind of go over. But again, we have psychiatric hospitals. Again, the state hospital stands today in Evanston. We have public housing, which kind of took the role of the poor farm and the workhouse. Foster care, took the role of indentured servitude. The psychiatric residential treatment facilities and residential treatment centers, PRTF and RATC, have taken the role of sort of the orphanage. And then we have juvenile detention and county level operated detention facilities, which have taken the role of those reform schools. Although the Wyoming Girls School and Wyoming Boys School kind of have that legacy as well. And then on this side, we have this clear separation here. We're now, nursing facilities. The poorhouses kind of turned into these convalescent or rest homes. The rest homes turned into nursing facilities. Skilled nursing facilities today are really the current incarnation of that. And then on the training schools, Medicaid kind of licensed those. Now there's what's called the ICF IID, or Intermediate Care Facility for Individuals with Intellectual Disabilities. Another acronym there. Those were kind of established in the 70s and 80s to kind of license those training schools and provide Medicaid reimbursement for those. And so the Life Resource Center, or the state, what was formerly the State Training School, is now the Life Resource Center, is an ICF IID. The new development, I think, in this time period from the 1950s to today was really the role of these home and community-based service providers. So this was really, kind of moving away from institutional care and moving back into the community setting. And so we now have a lot of people with physical disabilities, people that need help with daily living, a lot of people that would otherwise be in nursing homes, and people with intellectual disabilities are being served today in the community by these HCBS providers. So that's kind of I think, an interesting kind of seeing the historical roots. These institutions didn't just spring up overnight. they really have these deep roots in society, specifically American society, and sort of the English history that we came from, as well as sort of the county and state financing of those institutions has sort of transferred, the role sort of transferred to Medicaid. So with that, that's kind of the history lesson. We do have some sort of Wyoming specific history here, showing the Wyoming Constitution. Article 16, Section 6 talks about necessary support of the poor. And we also have Medicaid being formalized in 1967. The little cover sheet there from the archives. So again, Wyoming began participating in Medicaid in 1967. And that's sort of a brief history lesson, kind of really describing, I think, significant differences between Medicare and Medicaid, despite the very similar sounding names. Chairman Wilson, I can wait, pause, take any questions in the history section now, or I can wait till the end. What is your pleasure on that? Well, we do have these sort of divided sections.
I think let's just go on ahead and let people kind of collect them up. Folks, remember, and those of you, some of you that were able to join a little bit late, rather than take questions throughout, because you know how often it happens that you ask a question on slide 21 and it will be answered in slide 25. So we will pause after the overarching Medicaid and just mark down the slide number, and I think Franz will just get it. We'll pause before the specifics on the DD, but otherwise let's just go ahead.
All right, thanks, Madam Chair. So just now we're kind of talking about more nuts and bolts on Medicaid eligibility and enrollment. I do want to point out before moving on that Medicaid has a vast library of reports, and they're extremely useful reports that have a ton more detail than this presentation. So we're happy to send those to LSO. Medicaid does them every year. There's the Medicaid annual report, which really is sort of the main compendium of data for each year. But they also do like a per member per month cost report, and they do a county report. They do a bunch of other smaller reports. And we can kind of talk about those as we go forward, but a lot of this information comes from those. And those are sort of like the gold standard of what is truth about the Medicaid program comes from those reports. So all these slides are really derived from them. And we're happy to provide those detailed reports to this committee and the LSO generally. So again, as I mentioned, the purpose of Medicaid is really this medical and long-term care insurance for certain categories of low-income people. So just having low income does not make you automatically eligible for Medicaid. And you can see some of the eligibility categories in that table. We sort of, put them in more, plain English here. Those aren't really the terms that we use in Medicaid speak, but we're just trying to sort of give you an idea of, what kind of categories make up the bulk of enrollment. So this is not everybody. I think there's probably a couple, maybe 1,000 average enrollment that's not on this table as far as other categories of folks. But these are kind of the big categories of people that are enrolled in Medicaid. Categories. Again, you have to kind of fit into one of these categories to be eligible. And I'm stressing that point because I think this relates to sort of Medicaid expansion. Those folks who are low income are not, the reason we have this issue in front of us is because those folks are not automatically qualified for Medicaid. If you're not a caretaker, if you're not a pregnant woman, if you're not a child, you're not eligible currently. These are some of how the income breakdown works for some of these categories. So we have in that second column the annual income limit that's measured in usually what we call the federal poverty limit, or FPL. FPL that changes every year. So I think currently in 2021 it's like $12,000 for a single person. So when you multiply, but it really also scales with household size. So if you have for a family of 3, it's not $12,000, or sorry, whatever 154% of $12,000 would be. It's $33,800. It's really that household income limit for kids that are below 6 years of age. And then once for kids between 6 and 18, it goes to 133% FPL and so on. CHIP kids of all ages, it's 200% federal poverty level. And then you can see pregnant women, family care adults, and so on. The SSI, Supplementary Security Income, I think is what it stands for. Supplemental Security Income. That's very, very poor and disabled folks on SSI. That limit is very low, as you can see. pretty much below 100% FPL, and you have to be qualified by the Social Security Administration. And then we have nursing home and waiver clients where the income limit is higher for the individual, 300% of SSI. But again, they qualify more based on their on the potential disabilities or need for assistance in participating in the community. People enroll by, there's multiple ways people can do it. We have a streamlined, standardized application. So that's standardized by the Health and Human Services, sort of a standard application that most states use. People can do it online. We have a call center that we contract with. They can do it by fax. They can come in person. But what changed relatively recently was in 2014, applications which had previously been processed somewhat manually now go through a rules-based eligibility system. So it really checks, it kind of goes through a flow chart of eligibility, and it's sort of an automatic way, allows sort of standardized and uniform and clean eligibility determinations in a much faster and automated way. So that's been a really big improvement in the eligibility processes that Medicaid's implemented. You can see that Medicaid does verify certain facts about people, and then we look at eligibility annually for continued eligibility. This slide is a bit of an eye chart, but it really kind of shows, so the total height of the bar graphs equals the total enrollment, and each little segment of the bar is the individual enrollment for a certain group of Medicaid members. And I think the biggest, the high point here is the big purple band here. Those are the Medicaid kids. And so you can see kids really make up the bulk of our enrollment. We have, low-income adults, the caretakers, sort of this blue. We have sort of pregnant women being the pink up here. And then we have sort of our SSI and institutional type populations at the very bottom, right? So our IDD folks in the red and long-term care in green and so on. So these stack up to equal the total Medicaid enrollment. So you can see, around 60,000 back in 2008. We had the Great Recession. A lot of these eligibility categories are based on income, and so that's really sensitive to economic conditions. And so we had increased enrollment during the Great Recession. That sort of plateaued, around 11, 12. We had the ACA-related mandatory expansion for kids. This was, again, the income levels for kids changed, so we enrolled more kids from 2014 to 2015. But right about the same time, we had this new rules-based eligibility system implemented. And you can see the effects of that. There was some cleanup of the eligibility that happened. And sort of the standardization and the improving economy has reduced eligibility, the total Medicaid rolls from around 70,000 people to below almost 55,000 people right before COVID. And then, of course, when COVID hit, Medicaid, as part of this public health emergency, was not allowed to disenroll people. So we have seen some growth that sort of tapered off recently, but some growth in the Medicaid program because of that. So again, kind of an eye chart, but we're packing a lot of information into this. Just kind of showing the trends, what are the major events that have happened in eligibility since 2008? What are the major groups, who makes up eligibility, overall numbers, that kind of thing. A lot of stuff here. Hopefully helpful. Moving on to the benefits. So I keep harping on this. Unlike private health insurance and Medicare, almost half the spending in Medicaid really is for long-term care services. And that could be, nursing home, community-based care for people who are frail elderly or people with physical disabilities, and also institutional community-based services for people with intellectual disabilities, developmental disabilities, and acquired brain injuries. Slide 28 kind of shows an overview of the benefits. So, the medical care is kind of what you'd expect in a traditional private health insurance plan or Medicare. Although mental health parity is in private insurance a little bit more recent, but generally speaking, it's a very similar benefit package as far as the medical side. Medicaid also does offer dental and vision, although those benefits have been pruned somewhat due to budget cuts. And then really importantly, this long-term care, right? The facility-based and institutional services. So we have nursing homes on the institutional side. We have the Life Resource Center in Lander that's largely Medicaid funded. And then we have the in-home services. And then there's a sort of a smattering of other benefits here. I think one of the highlights here is there's a lot of low-income Medicare members. If you recall, I talked about the Medigap plans a lot of people buy because Part A, Medicare only covers 80% of the hospital, stay on average. For for very low income people who can't afford Medigap insurance, Medicaid kind of serves as that Medigap plan. So we pay the cost sharing for certain Medicare, low income Medicare members. And so we get the bills, but we only pay the sort of the patient cost sharing component of that. That's kind of an important component of this other section down here. There's also what we call waivers, and we've used this word a lot. We have a whole section and a whole brief after this Medicaid section on the waivers that we operate. But when we talk about waivers, it's a little more general. The word waiver refers to waiving statutory provisions of the Social Security Act. So essentially getting out or relaxing certain provisions of the Social Security Act through a very detailed agreement between the state and CMS. And generally speaking, waivers are used to expand services and covered populations. And the goal of most waivers is, I mean, the secondary goal really is also this sort of cost containment, but doing it through sort of alternative service delivery means. And I think the real key example here is looking at home and community-based services. Those waivers, they waive certain provisions of the Social Security Act in order to offer services to individuals who would otherwise be in an institutional setting at far greater cost. So while they do sort of expand services and they do sort of expand these covered populations, they really do serve the state general fund and federal fund interest in containing cost overall. There's a lot of different types of waivers. You can see I have the bureaucratic, the citations from the Social Security Act. They're 1915B, 1915C, I, J, K, this alphabet soup of waiver types, but they kind of break down into three main categories. There's managed care waivers. So many states operate their Medicaid plans through by essentially contracting with private insurance. They'll pay the insurers a premium, just like Medicare Advantage, very similar to Medicare Advantage plans. 1915C through K are various options for home and community-based services, and the state operates, three of those. And then there's this what are called 1115 waivers, which many of you have heard about. These are what are called demonstration waivers, experiments. They're very, very flexible. We can waive a lot of things, almost any requirement under Section 1902, but they have to be determined by the Secretary to be likely to assist in promoting the objectives of the Medicaid program. There are also things that we can't be waived under 1115. FMAP, for example, is under Section 1903, so it's not something that can be waived by an 1115 waiver. But generally speaking, those are the most sort of creative types. And you can do a lot of different things, a lot of different creative things, as long as they advance the objectives of the Medicaid program and they are budget neutral to the federal government. So those are kind of the overview of waiver types. The presentation that we'll get into really talks more about the specific home and community-based waivers that we operate for individuals with intellectual disabilities and physical disabilities. When you look at the benefit cost, though, you can see we've broken these into various colors. So it's kind of, again, kind of small, but mandatory services per the Social Security Act are in red. So these have to be operated. If you're going to operate a Medicaid program, you have to offer these services. We have optional programs, which are either optional per state plan, like vision or dental, but they're also optional services that are waiver services. And then we have what are called EPSDT services, or early prevention, screening, detection, and treatment. And this is a benefit for children where it is sort of an optional service, but it becomes sort of a mandatory service specifically for children. So there's sort of a category between the mandatory and optional here. And you can see kind of the various services that Medicaid offers, ranging from the comprehensive waiver for individuals with intellectual disabilities, which costs us, around $110, $115 million a year. Nursing facility mandatory service, around 90 or so million. Then we got hospital inpatient, which is mostly mandatory. Prescription drug, largely optional, but there's a large component that's for kids. That's also sort of mandatory, and so on and so forth. So you can see kind of a list here of going down the list of which services really make up the bulk of Medicaid spending. Moving on to talking about federal match. As you all know by now, Medicaid is a joint federal and state partnership. And so the match, it's largely operated by the state, but we claim matching funds every quarter or so from the federal government to reimburse what the state has spent. And that FMAP, or federal medical assistance percentage, is set in the Social Security Act. It's set in statute as this formula. It's this ratio of the state's per capita income, so it's rolling 3-year average, to the national level. So the formula here is a bit of an eye chart, but basically it's this ratio that's important. So whenever Wyoming's per capita income is higher than the national per capita income, our FMAP will go down. When it's lower, it goes up, but there's a statutory minimum FMAP of 50%. So even if this formula would spit out a number that's much lower than 50%, we can't go below this floor. And if you compare states, you can see that generally speaking, poorer states have a much higher FMAP. You can see on the left here, I think somehow Mississippi got left out on this chart, but they have one of the highest. But you can see the FMAP can go, as high as 75%. And then Wyoming is in this group of states here on the right that has an FMAP of 50%. What's interesting about this, though, it has changed over time. So now looking at slide 35, on this left, you can see how what we did is the income ratio, so the per capita income ratio of Wyoming to the national average. So if we were with the national average, it'd be this dashed red line. The green line is that ratio when it's below the national average. Our FMAP has tended to be higher than 50%. And when it's above the national average, the FMAP goes to around 50%. And there's random fluctuations and bumps because, for example, we recently received a 6% bump in FMAP that's temporary to deal with the COVID emergency. So the FMAP, it's not necessarily equal exactly, but I think the important point here is that our per capita income has generally, since the mid-2000s, been higher than the national average. And so and this trend does not look likely that our FMAP is going to really get much better on its own. If this were a trend, going down, then we could anticipate our FMAP would increase, right? But that doesn't appear to be the case just yet. So we can pretty much forecast that, our FMAP will likely remain at 50% for the foreseeable future, aside from these statutory tweaks. What's also interesting, we did this analysis for LSO recently, was that when you look at that per capita income, there's a certain county in the state that has a dramatically different per capita income than every other county. So you can see that trend over time, the county in red right here, and then every other Wyoming county in black over time. And then you can see the distribution here in sort of these gray bars. So they're right around, I think everybody knows what county I'm talking about, is right above $225,000 per person on average. And then everybody else is kind of between, ranging between, $30,000 and $75,000. And what's interesting about this is if that county were not part of Wyoming, our FMAP would actually, our per capita income would actually drop below the national average, and our FMAP would actually increase. So in some ways, our overall calculation is dragged upwards by this outlier. No doubt other states have outliers like this, but I thought it was interesting just to point out for fun. Next section we're talking about is access. So we're talking about doctors. How viable is Medicaid's network? Can Medicaid patients readily access physicians? And generally speaking, we have a relatively healthy provider network. As of 2018, 99% of licensed and practicing physicians were enrolled in Medicaid, 100% of nursing facilities, virtually all hospitals, all pharmacies, and then most dentists. So dentists is kind of, again, they're hard to get. We have about 72% of dentists who are enrolled. That's much higher than the US average of 39%. But participation rate has fallen with dentists since 2015. We also have a significant behavioral health. Most behavioral health providers do take Medicaid. I think the most salient point here, though, is that access is really correlated with rates. So, and this makes total sense, right? The more you pay doctors and providers, the more likely they are to take those patients. And so what we've done here is we've graphed all 50 states based on the y-axis. There was a study that estimated the physician participation in Medicaid from 0 to 100%. And this data is a little bit old, it's 2013. And then we compare that with what's called the Medicaid to Medicare fee index. So how much does Medicaid reimburse as a percent of Medicare on average for these type of physician services? So each of these dots is a state. Wyoming is the red state. New Jersey is the outlier down here, where almost 39% of physicians participate in Medicaid. But you can see there's, I think, a clear relationship. And we kind of made some assumptions that, if you don't pay physicians anything, they probably won't participate in Medicaid. So there's, this line passes through the 0-0 mark here. And then it asymptotes, there's a limit to, over 100%. You can't get over 100%. So this kind of curve is not a straight line. But you can see there's a very, a good relationship here between how much you pay doctors and how many participate in Medicaid. So when we talk about access, I think there's a real key link there with how much we pay. And those rates, of course, are tied to cost, which again is tied to appropriated dollars. So when we look at overall costs, the most common way of expressing these costs, and you'll kind of see on a lot of these graphs, and I've kind of mentioned it before, is what's called the per member per month, or PMPM. We throw out PMPM a lot, but that's what it means. It kind of is this derivation of overall costs over this unit of eligibility called the member month. So the member month is, if Franz was on Medicaid for an entire year, I would represent 12 member months, right? Franz for January, Franz for March, or February, March, April, May, so on. And that allows us to deal with the fact that people churn on and off the program at varying times in the year. So it's not like eligibility for every single person happens or doesn't happen on January 1st. People churn on and off throughout the year. So we really measure eligibility through what are called member months. And if you divide the member months by 12, you get what's called average enrollment, which is kind of the enrollment for the year on an average basis. And the per member per month, we take the average costs for any given group over that period. So if I want to look at the PMPM for 6 months for a certain group, I would take the costs for that group in that period and divide it by the total member months of that group in the period. So it's kind of a way to standardize the costs in a way. It's very similar to like a premium, how like insurance premiums are done on a monthly basis. The PMPM is kind of like the cost version of a premium paid. And we can use this measure to compare trends over time in a standardized way, as well as to compare trends across groups. So when we look at the sort of very, very big picture history, this is going back to like mid 1980s. You can see the trend in enrollment on the left, right? This little panel here kind of shows, we had 10,000 people enrolled in Medicaid in 1982. That enrollment has grown. It peaked around 2014 with the mandatory expansion. And it's gone up a little bit since, there's a little bit of a bump here that I'm not showing. But you can see enrollment now is around 60,000 some folks. And this enrollment's grown largely because eligibility criteria, either at the federal or state, generally speaking at the federal level, has expanded eligibility over time. Whether it's people with intellectual disabilities, lower income kids, pregnant women, a lot of these groups have been added over time. And so you see all these bumps in eligibility come from those expansions. Now on the middle panel, you look at the expenditures, and we have sort of two groups here. We have the dark blue, which represents the nominal expenditures in terms of 2020 dollars, or sorry, in terms of just the dollars of that time period, right? So, Medicaid spent around $20 million in 1982. We currently spend around $550 million. But then you adjust that for inflation, and you can see that expenditures for Medicaid have been relatively constant since, the mid 2000s, on an inflation adjusted basis, around $550 million. And you look at the per member per month cost in the same way, our PMPM has increased from around $150 PMPM to around almost $800 PMPM now. On an inflation adjusted basis, it's, relatively, it goes up and down, but relatively constant since, the early 2000s. So generally speaking, Medicaid costs have sort of tracked with inflation, I think is the bottom line here. A little more detail for people that like tables. You can see, back to 2010, total expenditures, the average enrollment, which again, remember that's the member months divided by 12 for each year. And then we have the PMPM there. I'm not going to read these numbers out to you. This is just sort of for your reference. It's important to note, though, that the PMPM, when I say, okay, the average is what, 779 for 2020, it's not equal across members. Like any insurance plan, you're going to have a real skewed distribution of risk. So in Medicaid, the top 5% of members account for about 51% of the Medicaid spending. And the top 1% of members, which isn't shown here, is 21% of the costs. So really, there's this very skewed distribution of costs where the bulk of members really cost very little. I mean, if you look at, the bulk of our members are kids, kids are very cheap to insure. Generally, they're very relatively healthy. They don't require much medical care. And then the very, very tippy top, sort of the risk distribution, we have people in nursing homes. We have people with intellectual disabilities who have really severe needs, need one-on-one, round-the-clock care. It can be extremely expensive. So that's kind of accounts really for that skewed distribution of costs that you see. And they also vary by member type, right? So when this is a graph showing sort of Wyoming spending by percent and compared to the US average spending by percent. So the age group, people that are elderly in nursing homes, for example, account for 26% of the spending, make up 5% of the enrollees in Wyoming. People with disabilities, 45% of the spending, 14% of enrollees, and so on. But you can see the kids, again, very little percent of the spending, 20% of spending, 70% of the enrollment. So just reinforcing the point that the risk is not equal across these groups. And you can see here average PMPM or per member per month costs for the various eligibility groups selected. We're not including everybody here, but you can see the average enrollment here, average PMPM for the various groups. Another interesting fact, looking at births. So here in Wyoming, we have, this is total births that have happened since 1996 over time. So you can see that peaked around, the late 2000s or mid to late 2000s. The births have slowed down somewhat since then. We had around 6,000 births last year. Medicaid births, sort of as an absolute number here, so around 2,500 to 3,000 Medicaid births each year. And you can see the percent of total births paid for by Medicaid has dropped from around 45% around that time period, the mid 2000s, to a little over 30% today. It's also, again, I mentioned other reports that Medicaid has. Medicaid has a very comprehensive birth report that they do. They also have a very comprehensive by county report. So on slide 48, you can see the spending by county. Medicaid breaks this into PMPM by county, enrollment by county, enrollment by service. So there's a whole bunch of facts. If you want to know about your specific county that you represent, how Medicaid, how Medicaid applies to that. This is kind of an overview of the spending, but we have a lot more detail in that supplementary county report that Medicaid does. And you can see this is roughly, a lot of population based, obviously Laramie and Natrona County being the highest population counties. Fremont County actually has a higher Medicaid spending. I think this is kind of largely influenced by the Life Resource Center being in Lander. Probably, causes Fremont County being a big outlier because that's tens of millions of dollars, just for that facility. And the reservation, of course, it generally has a lot of higher Medicaid expenditures as well. So, fun facts there. Moving on to sort of administrative facts. On average, 95% of expenditures, Medicaid expenditures, go to medical services, and 5% go to administration. So this is a relatively low, lean ratio of administrative costs. If you look, for example, on the exchanges, generally speaking, the individual or small group plan will probably have an 80 to 85% medical loss ratio, which is the expenditures going to medical services. And then large group plans approach 90 to 95% on average. Medicaid would be kind of similar to those large group plans, but a little leaner. Because Medicaid doesn't have to do marketing, Medicaid doesn't do negotiation for its networks and having to negotiate all those rates and so on. So there is less of an administrative load there. So only 5% really goes to administration. Most of that's claims processing and eligibility. So that call center, for example, that processes most of the eligibility applications, that's around 4%. That's all contracted out to private companies. And then the state employees, represented by Terry and her division, make about 1% of total spending. Other interesting facts, we do pay, we recognize the Medicaid rates tend to be lower than Medicare or private pay, often significantly. We try to make that up by paying providers very quickly. That's a benefit, I think, that's overlooked in many ways. We pay very fast. So around four days is how long it takes for us to pay on average after a claim is received. Many private insurance plans will take 30 days, 60 days, really draw out those payables. We don't do that. So that I think helps keep providers a little bit happier than they would otherwise. We also have 99% of our claims now that are submitted electronically. That's a really big improvement. So it cuts down a lot of the paperwork, at least physical paperwork that had to be done before. And then we pay virtually everybody through electronic funds transfer. So A lot of it now has been moved online, essentially. Really, we're looking at costs, though. When it comes to, particularly from a legislative perspective, what really affects Medicaid total cost? And the way I kind of like to think about it in a very very simplified sense is if you look at like the volume of a cube, we got 3 dimensions of that cube, and one side we got enrollment, one side we got the utilization, which is how much people use medical services, and then the other dimension we have is the rates that we pay on a unit basis for each of those medical services. And those 3 dimensions, when you multiply them together, you get the volume of that cube, which is really the total cost. And so kind of breaking that down by table, you can see total cost on the left. That can really be considered a function of the total people that are enrolled in Medicaid and the cost per person. Each of those can be broken down into other factors, and we kind of break it down further and further. And what I want to point out on the very far right is how much control does the state really have over each of these issues. And so, for example, eligibility policies, we do have some control over eligibility, but we don't. A lot of the eligibility policies are set by federal statute, and so we can't necessarily change that. Demographic and economic trends, drive a lot of the income-based eligibility groups like kids and pregnant women, adults. We have no control over the state economy or the demographics of the state. Same thing with federal policies, right? So there's certain things we can control in terms of the enrollment and certain things we can't. As far as cost per person, when you look at health conditions, generally speaking, it's very hard to control the chronic conditions, how healthy people are. We have absolutely no control over aging. People are going to age. We can't stop that as much as we'd like to. As far as cost sharing goes, we have some control over that. But again, it's limited by federal statute and parameters there. And we also have some control over the services that we offer. But when you look, every time we necessarily have to go through budget cuts, the main thing that we have control over are the rates. And that's the very bottom. And we have very high control over the rates. And so whenever we have to go through budget cuts, JAC always sees this, that we do, generally speaking, rate cuts are kind of the way we get the bulk of our savings. And conversely, when we have, when we want to do rate increases, we have to request relatively large appropriations. So that's really the biggest variable, I think, that the state Medicaid program controls. And by extension, the legislature has to deal with, is setting these rates. So with that, that's kind of, I know this presentation had a lot of different topics, a lot of different areas we covered, and it was a little disjointed. We tried to kind of break it up into those areas. But I think, Chairman Wilson, to your point, we're happy to stop here and take any questions that people might have on Medicaid 101.
Okay, great. So remember that after this committee, they will go on specifically and talk about the developmental disability waiver. So if your question is about that, you might hold it. But otherwise, questions in general. And while the screen is being shared, which I think is probably a good thing to keep sharing because the questions might be about the slide, but I can only see a few of you. So you might just have to call out your name, let me know that you have a question and I will call on you. I hear nothing so far. Franz, I did want, while people are thinking over, I did have one remark on slide 23, which was, and so this is a remark more than a question, but for people's insight, the income limit for the folks who are falling into the disabled category, and correct me if I'm wrong, Franz or Terry, but just to point out, these are income levels for the individual. So many of you may know a person who is, say, 23 years old and living at home with their parents because they're disabled. The family's household income is not included in that, or actually, I believe even if the child is disabled. So this is an area where you do see families, I used to have some friends where the husband was an attorney and the wife was a pharmacist, but the child was significantly disabled. And so that child was on Medicaid. We certainly have had past and present legislators with family members falling under this category. So that's, if you just want to kind of point that out or flesh that out any a little bit, the services and the income is for the specific enrollee in this case, not for the household.
Now that's absolutely correct, Chairman Wilson, and a really good point. It is based on the income of the individual, not the family.
I'm going to let people think a little bit further on. I see Senator Furphy has his hand up. Just let me finish I was just going to say, Franz, I was going to say on slide 31, you had the benefit costs. I think if we collect any typos or that sort of thing going on forward, it would be helpful on that slide to say costs per year. And that's just because some of us are used to thinking in terms of biennium. So that you might, if you update this all and repost it, it would be helpful, I think, to have that indicated as per year. Senator Furphy.
Thank you, Chairman Wilson. I have two questions here. Follow up to what you just asked. On these disabled people, particularly, some of them are being handled by, for example, in Laramie, our ARC home. Is that reimbursement go directly to the facility when they're handling those children? Because that's the issue. Some people cannot take care of those disabled, particularly adults, especially single family or single parent mothers, and they can't physically handle that. So I'm curious about that payment. Then I have a question on the waivers follow up later, but go ahead.
And so you can give an initial answer, Franz or Terry. We may roll some more of that discussion into the DD waiver presentation probably.
Good morning. This is Lee Grossman again with the Division of Healthcare Financing, and I'll be happy to answer that question. Chairman Wilson, Senator Furphy. So for example, those developmental disability service providers, you mentioned the example of ARC and Laramie. Those providers are paid as any other Medicaid provider that you see on the screen in front of you here. And that includes, let's say, if this is a small independent provider, even someone who is enrolled and caring for a family member, they're still paid through the Medicaid claim system as again, any other Wyoming Medicaid provider.
Senator Furphy, did you have a follow-up?
No, that's good. I was just curious about that.
Okay.
But I do have a question on the waivers. One of the things that seems important lately is trying to keep elderly people in their homes versus sending them to nursing homes. And I'm curious about waivers. Does that allow, for example, a nurse to check on the elderly in their home maybe several times a week to make sure they're doing okay? Is that an appropriate use of Medicaid funds? Thank you.
Lee Grossman and Chairman Wilson, Senator Furphy. That's an appropriate example that you provided in terms of the services, specifically on the slide you see in front of you. That would be the Community Choices Waiver Program that provides services to older adults and people with physical disabilities in their home as an alternative to nursing facility care. So whether it's an RN, a registered nurse, or a CNA, those are exactly the types of services in terms of those in-home supports for individuals on that program.
And Madam Chairman, this is Stefan Johansson. I might just add to what Lee said here. In terms of our long-term care services that are offered through the waiver, it's important to note, and we'll get to that in the presentation, that folks on those waivers really need to qualify both in terms of financial resources as well as level of care. So the folks that get those services through Medicaid in their homes through the Community Choices waiver would otherwise qualify, for example, for nursing home level of care. And instead, those services are provided on a home and community based setting. So Senator Furphy, I think I hope that clarifies. It's not everybody on Medicaid who happens to be, elderly or have the certain conditions. They really have to qualify both based on income and based on their level of care assessment.
So just to flesh that out, that Stefan, and we all do a little bit of a brain dump after session, but so to Senator Furphy's question and just the general thought, elderly people who are in their homes now may not be eligible for Medicaid because they're just in their home. They're not qualified for nursing home care. We actually cut a number of those programs in this last supplemental budget, didn't we?
Madam Chairman, yes and no. So there, in terms of the Medicaid services, there were 2.5% across the board reductions that did impact those home and community-based service providers, including long-term care providers. But I believe what you're referring to is the kind of a non-Medicaid program that we have in the aging division called Wyoming Home Services. It's a much smaller program in terms of its overall budget, but it's basically intended for a smaller benefit, type of package or services that are offered to folks who may not qualify for the Medicaid Community Choices waiver for those in-home services. Largely that is provided through senior center networks around the state. Yes, it was a proposed budget reduction, but through the work of the Joint Conference Committee and the legislature, a portion of those reductions were added back. And then the department will, for the next fiscal year, so kind of rounding out this current biennium, we will fund Wyoming Home Services at its full amount for the remainder of the biennium. But Madam Chairman, to your point, I think it will be an ongoing conversation in kind of restricted budget times that we all find ourselves in of what the long-term future of a state general fund only program like Wyoming Home Services, what that future will look like. But I think fortunately at least for the next fiscal year, I know it's temporary, the department has committed, again, in partnership with the legislature, to fund Wyoming Home Services for the rest of the biennium.
Great, thanks. Representative Ottman.
And Madam Chairman, I'm sorry to interrupt. Terry just reminded me, I was remiss, I forgot to mention, part of our step 2 budget reductions did include the elimination of the PACE program, which was only here in Cheyenne, and it stands for the Program for All-Inclusive Care of the Elderly. It was basically a pilot project that started years and years ago, kind of from the federal level, where states or communities could experiment with an alternative service delivery model for long-term care services. Because the state of Wyoming and Department of Health have invested heavily in the long-term care waiver, the Community Choices waiver, unfortunately, when we were directed to make the level of cuts that we were directed to do, the PACE program was on the list for elimination, and we did make that change recently, where those members who were served through PACE have either transitioned to waiver services here in Cheyenne or have been transitioned off the PACE program. So I wanted to make that clarification. Thanks, Terry.
Okay, Representative Ottman.
Thank you, Madam Chair. Can you hear me? Okay. I just wanted to say, as I was listening the last couple of days to the Revenue Committee and saw a real similar and possibly the same presentation, I wondered why it was on revenue and then also our committee meeting today. But that's becoming more and more clear to me, especially watching the historical part of it, how it came to be. And my question goes to how we serve the people, and then what choices we have. Like for instance, and I won't make this long, but for instance, say there are people that need services. They need hospitalization, or they need things. They may need an operation, or they may need care. But if they are homeless, do they need to have an address and things like that? I happened to meet a gentleman about a week ago that was telling me that he was going in for an operation, but he was homeless. And that goes along with my another question, is that when we offer services and people are on these waivers, is there any criteria, like if you do they need to be drug-free or alcohol-free, or can we even say anything about that? Also, how about children that are born to drug abusers? I mean, is there, it seems to me that that is where a lot of the costs are, and how to determine that is very, very delicate, I realize. So that's kind of my first question. And then my second one is, if an elderly person went to live with family members, and the family member then may need to cut back on their employment or quit, is that family member entitled to some sort of caregiver reimbursement? Thank you.
So I'm going to let the department manage the second one, but I can give you some answers for the first. The reason that there is some similarity of presentation, although it's not entirely overlapping. So on the Labor Committee, we, of course, oversee Department of Health and the Medicaid program as it currently exists, which is what this presentation is about. This presentation is not about Medicaid expansion. This presentation is about the existing Medicaid program in Wyoming. And I felt that that was really important for all of us to understand. Personally, one of my goals is to never hear the words Medicare expansion on the floor ever again, because it drives me crazy. But circling back, the reason it's on the Revenue Committee, there was a Revenue Committee presentation, is because Management Council assigned the topic of Medicaid expansion to the Revenue Committee as a revenue source. So those are two slightly different Medicaid discussions. Then, just from my own knowledge, as far as the enrollees, if we go back to what the categories were, the average person between the ages of 19 and 64 are not eligible for Medicaid in Wyoming. So a homeless person who needs an operation is not paid for by anything for the most part, unless they perhaps are a veteran or something like that. That becomes part of the uncompensated care for the hospital, which you'll be able to hear about at the end of this afternoon. And of course, that's paid for by, depends on how your hospital gets its funding, whether taxpayer dollars, raising the rates on insured people, fundraising banquets that hospitals have. That's who pays for that. Because you can see on this slide 23 that, most homeless people, let's be honest, are adults between the ages of 19 and 64, and they're not in this category. So that's my answer on that. And actually, department can also address issues of, my understanding is that I don't think CMS allows for drug testing for the services, but you folks can answer that better than I.
Madam Chairwoman, this is Terry Green, State Medicaid agent. We are able to pay for numerous laboratory tests, and depending on the medical necessity of that. We do not use any kind of drug testing criteria to qualify any of the eligibility categories.
And Madam Chairman, this is Stefan, to Representative Ottman's second question about, hypothetically an individual who goes to live with their parents, and now the parents or caretakers potentially have to reduce their work or quit their job to caretake. Would they qualify for Medicaid? The answer is yes, if they meet these criteria. So for family care adults, and Terry can correct me if I'm wrong, you can see the federal poverty limit there for the family care adults on kind of the middle of the table. That's a very low income standard, but essentially a caretaker can qualify if their annual income or household income is less than 53% of the poverty level. And in that case, Representative Ottman, potentially that caretaker could qualify for Medicaid coverage in addition to whatever services their ward or their child might qualify for within these categories as well. So hopefully that answers your question. But to Chairman Wilson's point, generally speaking, non-disabled adults in Wyoming between kind of that age group of 21 to 64 years old, those non-disabled adults currently do not qualify for Wyoming Medicaid unless they meet one of these categories. And that's really where the discussion about the optional Medicaid expansion comes in. That's the kind of debate that's going on about covering those non-disabled adults that are either uninsured, underinsured, or some of the populations that you mentioned.
So let me just clarify there, Representative Ottman. Was your question whether the caregiver would be able to be covered by Medicaid for themselves, or was your question whether their services are reimbursable by Medicaid for their elderly parent? I mean, can they file a claim for reimbursement for their work? Was that what you were asking, Representative Ottman? I see you have your hand up again.
Yes, thank you, Madam Chairman. That was, for instance, and I'll just give you a for instance, a friend of ours took in their parent who was, it was either go to a nursing facility or come into their home. They weren't bedridden or anything, but they were not able to care for themselves. So they took them in, but this put the woman of the house where she could not work because she had to be there. And so where the covered person used to get some help, now that they were in with their family member, there was no help given now. And that really put a stress on the family because the man was still working and making enough money to support his family, but the woman now was not bringing in an income to assist with that. So, there was just a problem there, and we were wondering how that could be addressed. Am I clear? Thank you.
Steppen or whomever.
Grossman here again with the Division of Healthcare Financing. Chairman Wilson, Representative Ottman. So the situation that you described, I think, is one that we here at the department know is one that's all too common across the states in terms of caregivers, whether it's for a parent or perhaps a family member with a disability. And one way in particular, and thinking of the Community Choices Waiver Program that we administer, is respite services that provides those personal attendant services to the individual who is receiving services through the Community Choices Waiver, for example, so that that primary caregiver, if you will, who for example lives with this individual, can have a break. That's really the core intent of that particular service. However, perhaps more directly to your question, that caregiver is not necessarily billing us, or we're not covering for their time, if you will, through any types of claiming or reimbursement.
Any more questions on this particular section?
Madam Chairman, this is Representative
Flitner.
Thank you, Madam Chairman. I have a couple questions. Slide 47, births paid by Medicaid. Those Medicaid births are going down. Do we know why? And secondly, when a child is enrolled in the Medicaid program, say for instance at birth, do they generally age out of the program, or do we know if some of those children come off of the program because the mother's situation has changed? Do we have any data on that? Thank you.
So Chairman Wilson, Representative Flitner, I think the Medicaid births are going down for two reasons. One is there's an overall decline in the total birth rate, right? So the absolute number is going down for demographic reasons. But this data really goes back to, it doesn't include necessarily the pandemic effects. And so we've kind of yet to see what will happen there. But I think the improving economy, generally we see people at the upper end of the income eligibility bands leaving Medicaid as the economy improves. And so there is significant churn, what we call it, people coming on and off Medicaid. And so the fact that there's fewer pregnant women that are qualifying for Medicaid likely means the improvement in the economy over this time period, since the Great Recession really, likely decreased Medicaid eligibility there. Now, with the other question about the kids, I would say that most of the kids who are born to pregnant women who are on Medicaid would likely also qualify for Medicaid for a continued period of time. So the mother has I think 60-day period of postpartum eligibility. So once the mother gives birth, they have 60 days of Medicaid eligibility, after which they would likely not be eligible for Medicaid after that point. But the child would certainly either be eligible for Medicaid or CHIP. If you recall, the CHIP program covers kids up to 200% of the federal poverty level. So kids may, and now that CHIP program has recently been brought in-house, there's a much more seamless transition between those groups than before. Does that answer your question?
Yes, and Madam Chairman, just one other, when would is there an age out period? I mean, is it at the age of 19, 18?
Madam Chairman, Representative Flitner, it depends on the eligibility category. So for example, foster care kids are allowed to remain on Medicaid well past 21 to 26 years of age. But that only applies to foster care kids, whereas most Medicaid kids, I think it's either 21, right, is when they would age out from the child eligibility group.
Thank you.
Okay. Any more questions before we move on to the DD waiver? Representative Clifford.
Thank you, Madam Chairman. I have a question. I'm not sure if you guys could answer this, but I had a constituent reach out to me and knew that we were going to do this very informative and educational meeting today, which I totally appreciate. I was concerned about, do you guys keep track of the maternal health morbidity rates? And I'm asking because I know at one time the reservation had a very high rate. Do you guys keep track of that, or do you have access to that, or could you point me to somebody that does keep track of that? Thank you.
Department.
Madam Chair, thank you for that question. We have a very dedicated group in the Department of Health that's working on maternal morbidity. And there are folks from both the Public Health Division and the Medicaid Division working on that. They do have some very basic reports available at this time. And I'm happy to connect anyone with that group or try to answer questions in relation to the maternal morbidity rates.
Terry, would you just send Representative Clifford an email just so she can respond back to you and ask for whatever she wants?
Madam Chair, yes, happy to do that.
Okay. Okay, any more? All right, very good. Let's go ahead and move on to the DD component.
Okay, again, good morning, Madam Chairman, members of the committee. Now we're on we're calling Medicaid 102 on the waivers. And in this case, we're not just talking about IDD, we're talking also about people with physical disabilities or frail elderly who are also served in their home. The waivers, what are they? I talked about kind of technically what a waiver means as far as waiving the Social Security Act, but for all intents and purposes in Wyoming, really what we're talking about here are these home and community-based service waivers, being sort of an optional way for states to pay for long-term and habilitative services in a home or community setting. The word habilitative is very, very specific to be distinguished from rehabilitative. And I'm not sure I trust myself to give an accurate definition between the two, but really it's sort of more of a maintenance kind of aspect of people that may not have had functions before, but you're sort of working to try to improve them over time. Whereas rehabilitative is like, well, if you cross the street and got hit by a bus, well, you used to be able to walk, but now you're getting rehabilitative services to be able to learn how to walk again. So the difference between habilitative and rehabilitative is pretty, it's nuanced, but it's very, very important when you're talking about sort of why these services are kind of a waiver from traditional Medicaid services. So prior to 1981, we really only paid for these services in an institutional setting. But since then, these waivers have grown to now cover the majority of people needing long-term care. I think it's up to over 60% at this point of people who require long-term care that are served in the community on the community choices waiver. And then with IDD, it's a much higher fraction too, because the Life Resource Center, about 70 clients out of 2,000 are the only people that are still in an institutional setting today. So as I noted, there's kind of three waivers that or technically 4 waivers that we operate. There's the comprehensive waiver and the supports waiver. And these are for individuals with intellectual and developmental disabilities, as well as acquired brain injuries. And then there's the community choices waiver, and that's for seniors and individuals with disabilities who require an institutional level of care. And then we also operate a smaller children's mental health waiver. This is really for getting higher income children that have significant behavioral health needs to qualify for Medicaid. So those are the 4 major waivers that we offer. I think there's a couple other minor ones like the pregnant by choice. Those are minor ones that we offer, but these are the major ones. When we talk about waivers, we're talking about basically these 3 for the most part. So why do waivers? There's 3 main reasons. One is individuals really prefer to receive those services at home or in the community. The second major reason is that they generally cost the state less than institutional alternatives. And the final reason is we have a really strong legal obligation under both federal, the Supreme Court Olmstead case, as well as state level cases, the Chris S. and the Weston settlements. So those are 3 very, very good reasons why we have waivers. I'll kind of get into the details here. Olmstead is really big. Olmstead, this case it was a case from Georgia decided in 1999 and really found that unjustified institutional isolation was a form of discrimination, so sort of a civil rights issue. Basically, the idea that institutional placement, it perpetuates these unwarranted assumptions that people are unworthy of participating in community life. That was one judgment, as well as it's diminishing their everyday life activities of individuals. I think this laser pointer may be too distracting, so I'm just gonna turn it off. And Olmstead found basically there's a 3-part test for individuals essentially having a qualified right for people with disabilities to receive support in the community. So essentially an obligation for the state to provide that support in the community versus institution. And that's really whether or not that treatment team determines that the community supports are appropriate, that the transfer from an institutional setting is less restrictive and not opposed by the affected individual, and that the provision of service can reasonably be accommodated given the resources available to the state and the needs of other similarly situated individuals. So Olmstead really put a strong burden. I mean, there was this movement of deinstitutionalization before, starting in the 60s and 70s and the 70s and 80s, particularly for individuals with intellectual disabilities. But Olmstead really was sort of this culmination of this sort of legal obligation to do so on the federal level. In Wyoming, we have also a really important precedent called the Weston settlement. This particularly applies to individuals with intellectual disabilities. And this relates to our institutionalization of individuals with intellectual disabilities at the former Wyoming State Training School, now the Life Resource Center. And again, as I mentioned in the history section, that was established in 1907 as part of this movement to move people with intellectual disabilities into state care, as opposed to sort of these county level poorhouses. So it really was meant as a reform at the time. At its peak in the 60s, it had over 700 clients. Today we have about 70. So Weston in the 90s was kind of this, again, a kind of a culmination of that deinstitutionalization movement in Wyoming. Really, the settlement agreement where the state agreed to not only improve the conditions at the Life Resource Center, which were, quite frankly, quite deplorable at the time, but also expanding the availability of community resources and support to those class members, to community programs. So Weston is really a significant, legal settlement in Wyoming, which justifies from a legal perspective the expansion of community services on the IDD front. Now, if you look at it on the cost side, again, we're talking about PMPMs here, right, per member per month versus the benchmark. So the benchmark is kind of that institutional setting. And you can kind of see, not only is it better for individuals, but on average, the PMPM cost is significantly lower on the comprehensive waiver than it is for the two benchmarks here, which is the Life Resource Center, which is very, very high, right? I mean, $27,000 a month, or nursing home care, which is around $5,000 per member per month. So in some cases, it's comparable, but based on this Life Resource Center benchmark, it's far cheaper. And then you look at the community choices waiver. So these are individuals with physical disabilities served in the community, about $1,700 per member per month versus the nursing home benchmark of around $5,000 per member per month. So again, significantly cheaper for the state and federal government to provide those services in a home and based setting than in an institutional one. When we look at the children's mental health waiver, the benchmark is a little trickier to define because people aren't in PRTFs forever. So you're kind of looking at kind of a mix of their institutional stay and their community stays. But we estimate that the mental health waiver is cheaper on average than the sort of a PRTF setting or psychiatric residential treatment center, facility setting as well. So on all counts, really these waivers are cheaper to the state and federal governments than their institutional alternatives. As far as eligibility goes, this goes kind of back to our eligibility slides, but much more detail. Community choices waiver eligibility is based on age. So if you're over 65, or if you're 19 to 64, but designated by the Social Security Administration as disabled, you qualify on that ground. There's also an income limit, so you can't make more than 300% of the SSI level, which is about $2,300 a month. And you can also not have more than $2,000 in assets or resources. And that excludes a vehicle and a primary home. You also, in addition to these criteria, you also need to require a nursing home level of care. So we do this assessment called the LT 101 that's conducted by an independent party. We have public health nurses that are part of the public health division around the state. They go out and assess people on this assessment. So it's not done by providers, which is, I think, important. It's really this independent look. And the LT 101 sort of looks at a lot of things, but I think, the things that would make sense for a lot of people here, for the layperson, would be what are called activities of daily living. And you can see some examples there. Can a person transit to the bathroom and use the toilet? Can a person prepare meals for themselves? How much assistance do they need bathing and so on? So there's kind of multiple criteria for eligibility, sort of a combination of age, resources and income, and then also this sort of functional needs assessment. It's kind of my chart, so I'll kind of go through this piece by piece. Again, we're kind of talking about the community choices waiver, so not the intellectual disability side. But on the left here, you're going to see kind of a statewide look over time. So looking from 1990 to 2040, and by county, the percent of the population that's over 65 years old. Right now, we're at 2020, so that's the dashed line. The state average for each of the counties is the same. It's going to be this black dashed line here. So that's the state average. And then each county is going to have a red line here. This trend of, how is that county population aging? And so when we talk about this silver tsunami, that's kind of the cliche. It's a very slow moving tsunami. It's not this sudden wave that's going to hit us in the next year or two. It's hitting us over the next, decade or, next couple decades. So you can see for Hot Springs County has a, generally speaking, older than the Wyoming average population. It will get, kind of follow that trend, this sort of growth in the aging population. But we're just starting to hit the very beginning of it. If you note where the dashed line is relative to this curve, it will get, by 2030, 2040, we'll probably have an additional 5 to 10% of our population will be over 65. And that's just a function of the baby boom and the demographics that we face, as well as kind of decreasing on average, fertility and so on. Certain counties like Albany County and Teton County are below the state average. And then counties like Hot Springs, Johnson are over the state average when it comes to this sort of aging population. So this kind of shows sort of county trends, over time. I think it's kind of interesting, like sublet, was around the average. Sublet counties participate or is projected to age significantly more rapidly in the next few years. So there's some just interesting trends here. You can kind of look at your own county and kind of see what the future foretells with respect to an aging population. And that demographics really drives Medicaid long-term care in the community choices waiver and nursing home. Generally speaking, we have a whole report on this. Most Americans and Wyomingites are not prepared to pay for long-term care costs. And so ultimately Medicaid kind of ends up being the safety net payer of last resort, where people might have gone to the poorhouse, last 100 years ago, people are now going to nursing homes. And fortunately, in this case, we're also giving a lot of people support in their home and community-based settings. So on this top graph, you can kind of see the trend in Medicaid long-term care enrollment. Again, it's a stacked bar graph. So the total enrollment in long-term care is reflected by this upper bound here, right around, starting around 3,000, a little over 3,000 in 2010, and a little over 4,000 today. And then you can see it's divided into sort of nursing home, which is this brown bar or brown set of bars, and home and community-based or community choices waiver setting, the blue. So I think what's the takeaways here is in 2013, we uncapped the waiver. There was a policy decision made by the legislature to no longer have a waiting list for the community choices waiver. And so that waiver has really absorbed most of the growth in long-term care enrollment. You can see of the enrollment here, the total growth, right, from around 3,500 to 4,000, a little over 4,000, that growth has almost entirely been in community choices waiver in the blue section, whereas nursing home growth has been relatively flat and declining. And from our perspective, you can see here again, now we're separating out that enrollment by the lines here. So it's no longer stacked, right? These are actual just enrollment by group. The community choice waiver enrollment really has gone up since that time. Nursing home enrollment has been flat or declining. And as a percent of total long-term care, again, kind of looking at the same thing, we've gone from around 48% of people being served in home and community-based settings in that policy shift to over 60% today. So that's a really positive, in our opinion, very, very positive shift, not only for people's choice, for people's living situations, but also for cost to the state and the feds. Moving on to the IDD side. So this is a mistake here. This is a typo. I need to address this. No, actually, no, it is the comprehensive supports. I'm correct. Sorry, it's not my mistake. This is the comprehensive supports waiver. So we're dealing with individuals with intellectual disabilities. The eligibility here is a little different. So for IDD, people with intellectual or developmental disabilities, it's all ages. There's no age limit or criteria. But for people with acquired brain injuries, you have to be over 21. And the idea is it would be unlikely, I guess, I mean, the rate of acquired brain injuries among children is hopefully, unfortunately, very, very low. But it's really intended for adults that have had those, 21 plus with acquired brain injuries. And Tyler has something to add to that.
Yeah, sorry. Additionally, if an individual has a brain injury before the age of 21, it's considered during that developmental period. So if it has an impact on the person's intellectual functioning or capacity, then they could also be considered to have an intellectual disability through that brain injury. So that's another reason why we separate those two populations by age.
Thanks, Tyler. Yeah. Glad you're here. There also is an income limit. Again, similar to that 300% SSI, but as Chairman Wilson, you noted, that's really for the individual themselves, not their family. Assets, same thing. It's really for the individual themselves. That resource limit is $2,000, excluding the vehicle and primary home. And we have another assessment called the LT 104 that's done for individuals with intellectual disabilities, different from the LT 101, although the LT 101 is also used for individuals with acquired brain injuries. And finally, they also have to have this diagnosis. So they're, by a qualified provider, they have to diagnose them with an intellectual or developmental disability or an acquired brain injury to basically qualify for this program. And what happens is there's two waivers. So people with intellectual disabilities can qualify for or choose. Generally speaking, there's a wait list right now, so people coming off the wait list will be put on the supports waiver. And this budget is capped. So we have a capped budget of $27,000 per year, but it's very flexible. It can be spent on a wide variety of services. And then there's a significant population of people on the comprehensive waiver, which is much, generally speaking, as the name would imply, larger and more comprehensive, not capped budget. These are individualized budget amounts. These are set by a formula that sort of takes into needs and living situation. So we have an assessment of each individual person that determines sort of what's called a level of care that ranges from, I think, like 1 to 6. And that level of care determines sort of this individualized budget amount, or IBA. So these IBAs vary by person. And here's kind of a bit of an eye chart. I'll try to walk through this to you. A lot of information packed on here. This kind of shows total enrollment for individuals with intellectual disabilities. But we had this IDD waiver redesign effort around the same time as that long-term care uncapping. And so we shifted waivers. So you can see the waivers changed. We used to have this adult IDD waiver population. We had a child IDD waiver population, and we had an ABI waiver, or the acquired brain injury waiver. So those are the three waivers before. We had this redesign, and we gradually shifted people to the new waivers. So now we have people that are either on the comprehensive waiver, and you can see that enrollment, pretty much people were grandfathered at this point. The supports waiver was totally new. So this population was grandfathered, and it's gradually, the comprehensive waiver enrollment has gradually kind of trended down slightly as the wait list has really taken up, people come off the wait list, they go onto the supports waiver, which is this blue, light blue group up here. So total enrollment under these programs has grown from around 2,200 people in 2008 to a little over 2,500 people today. So slight growth in that over the last decade or so. We do, however, have a wait list. So this is really important to know about the IDD waiver. Unlike the comprehensive, the community choices waiver, which does not have a wait list, you can see how the wait list is shifted here with the IDD population. So we had the child DD again, we had the adult DD, and we had the ABI. And a big factor behind the waiver redesign was this growing wait list. In the sort of early part of the 2010s, this wait list was growing. There was more and more pressure for the legislature to, we need to serve more people. So that sort of resulted in the waiver redesign. That wait list was able to be reduced. But in recent years, due to budget cuts and budget pressures, that wait list has now begun trending up again. So now, as you can see, it's all the supports waiver wait list. But I think it's important to note that trend. It sort of reached a low point in 2016, 2017, but it has certainly increased since. So with that, that's really wraps up our presentation on the waivers. Happy to pause here for any questions before I turn it over to Stefan for the Title 25 portion of our brief.
You're muted, Chairman Wilson.
Sorry. I was going to say that before I start taking questions, the agenda does say Title 25 starting at 10:45. And so what I'm going to do after I take these questions, if we have time left, is I'm actually going to give us a longer break, because I did invite other members of the legislature and all to dial in. And so if people looked at the agenda and said, well, I really want to know about Title 25, I'll come in at 10:45. I don't want to start early. So that we'll, but hopefully there'll be lots of questions. And I'm sorry, I wasn't looking to see, I see a bunch of hands, but I didn't notice whose was first. So I'll call on Representative Connolly.
Thank you, Madam Chair. I've got a few questions. So I'll just start, I think, backwards. So I'm curious about this real increase in the waiting list. And could we get more information about that?
Chairman Wilson, Representative Connolly, the wait list is really a function of how much funding is available to move people onto the waivers. The waivers, as you know, are fairly costly, even the supports waiver. So we do need, and it does tend to grow over time. So this is really subject to appropriations and the availability of funding. And we had, and as you recall, in 2016, there was a pretty significant budget cuts. We also had recent budget cuts just this last biennium. And so we haven't been able to fund as many people off the wait list just for really, it really comes down to the appropriation. And I could, Lee and Tyler can certainly correct me if I'm wrong there.
I was just going to insert one other thing, which is looking at the slide. My recollection is the 2015, we actually appropriated a large amount of money to take people off the wait list. So the drop there was, not to disagree about the appropriations, but the people who are on the wait list, in spring of 2015 if we had not made that extra large appropriation, probably the rise wouldn't have looked so big, but that, I don't know if that really makes sense. But so I guess, in other words, the decrease in wait list was also related to appropriation. We've done periodically, Labor Committee has done evaluations to try to discern whether or not, and I would appreciate the department's input on this, whether or not our, sort of per capita person on this type of service is higher elsewhere than others. We've heard anecdotal accounts of people deliberately moving to Wyoming because it was easier to get services. I just throw that out there. Go ahead, department.
Chairman Wilson, just to follow up with a little more information in terms of the wait list. We have publicly available information on our website that we update monthly that gives a little bit more detail on the status of the wait list. The report that we have just received this month, we crossed the 500 threshold in terms of number of individuals on the wait list for the first time since that waiver redesign that we've been discussing here this morning as well. So obviously this is a very key programmatic element that we watch very closely. It's something that is a constant point of discussion with stakeholders, since it's something that is obviously of great concern. And we at the department certainly realize that each one of those 501 individuals on the wait list has a real assessed need. And right now, for people who are being funded from that wait list, it's about 3 years on average in terms of how long people have been waiting for services. So that's from when they were deemed eligible and placed onto the wait list. I would also just add that it's a first come, first served sort of wait list process in terms of how those individuals get funded, with the caveat that we do have emergency criteria that's outlined in our administrative rules, by which people can essentially petition for immediate funding onto waiver services. Just as a couple of examples, that could include the loss of a primary caregiver who might have been delivering the bulk of even informal supports to an individual. Earlier, we touched on homelessness. If there's an individual who's certified to be eligible, who has experienced homelessness for at least 30 days, they can also receive emergency services. Just as a few examples for what those situations can look like.
Go ahead, Representative Connolly.
Thank you, Madam Chair. And thank you for that follow-up question, because honestly, my questions go together in terms of trying to understand what the need of our residents are and where the gap is. And so hearing that there's a 3-year waiting period, now I'm curious about what happens to those individuals in that 3-year period. I'm interested as well in cost shifting. So are we not providing services under X, but then other services under Y are being provided? So I'm curious about that. And if there aren't services that are provided, are people harmed because of that with long-term effects?
Department.
Chairman Wilson, Representative Connolly, this is not only a question for the IDD issue, but also for long-term care and aging. I think there is a significant unrecognized amount of unpaid care that goes on. Family members just taking care of family members, and there's a huge burden of that. And the ARP can certainly tell you about that from the long-term care perspective. That when there's no paid support, it's family members that bear the burden. And I would assume, and it's basically the same case here, but I'd happy to let Lee and Tyler kind of weigh in if it's on any specifics for IDD.
Chairman Wilson, Representative Connolly. So the majority of people on the IDD wait list are children. So when you talk about what's the impact for those, right now it's about a 3-year time period. That impact is typically parents, other family members, essentially providing those informal, i.e. unpaid supports. That's really a lot of the feedback that we hear, and when certainly when I talk to folks who have a loved one on the wait list, you can really hear it in some of that feedback. In terms of just any kind of long-term impacts that you also mentioned in your question, really that's that's the reason for having that emergency criteria. So again, if someone is experiencing that type of an emergency, a significant change in their condition, they can essentially petition the agency for that, that emergency criteria as well.
I might ask here, the DD preschools, you know, there was some discussion in session about whether to shift that programming from Department of Health to Department of Ed. Do you want to just talk a little bit about how this the young children population might be served, receive some services through the DD preschools, if they are?
Chairman Wilson, I think the name is kind of similar, but I think that when we say DD preschools or the early intervention program, that's serving a much broader population of children who aren't necessarily having intellectual disabilities, but they might have developmental delays. And so, you know, like in town, you know, we have Stride Learning Center, which serves a variety of kids through speech therapy, physical therapy, trying to basically catch kids up. You know, my own son, you know, got some physical therapy from Stride. So, and he doesn't have you know, it's a developmental delay, but not necessarily an intellectual or development disability. So I think it's a very different kind of population that's served here. The waivers here serve, I think, a much more population with much stronger needs and sort of long-term care needs in general.
Right, but I was just running to Representative Connolly's question about who helps these children when they're not on this. I'm just trying to see, you know, how the gaps might be. I recognize that the gaps are not fully filled or even mostly filled, but just so that we all understand, you know, because so often during session, many of these programs people only hear about when people do the budget presentation on the floor, you know, in a day and whiz by these things really fast. And we may not see what the linkages are as far as serving the population. So I was just wondering if there might be some, you know, overlap.
And Madam Chairman, this is Stefan. That's a great question. I think a few comments I would make is in terms of, you know, the population that the developmental preschools or what we call EIEP, the early intervention education programs serve. It's really in two buckets. One are those birth to 2-year-olds. And that is, you know, as Franz mentioned, both to try to catch very young children and infants up on developmental delays, physical therapy, things like that. And likely in all of these populations, Chairman Wilson, could be some overlap with folks waiting on a wait list for any program, including the waivers, could be served by these community resources, as well as, you know, for maybe an older child population served from a special education standpoint by the school district in many ways. The other kind of section of our early intervention or developmental preschool program is really more education based, and that's the 3 to 5-year-olds, or what we call Part B of the early intervention program. And that's again, like I said, more kind of education driven for things like speech therapy, other types of cognitive therapy, to try to serve children with age appropriate peers, to, as Franz mentioned, for lack of a better term, to catch kids up with certain types of developmental delays before they enter the school system. So, Chairman Wilson, it really is a mixed bag, and we could certainly look at some overlap. I'm not going to promise anything because that crosswalk analysis could be difficult, but I assume when folks, especially children, are on the waiting list, there are community resources both on the education side, the mental health side, that can serve children of that age, but it's probably very diverse depending on the community.
No, I wasn't expecting you to do any specific crosswalking. I'm just trying to help, especially our newer members, see what we've got. And Representative Clifford, I do see your hand. I'm just trying to clean out Representative Connolly's outbox there. More, Representative Connolly?
No, thank you very much, Madam Chair and Department.
Okay, Representative Clifford.
Thank you, Madam Chairman. I know in the past with the working with the federal government, the Department of Health, you all there, and the tribes here at Wind River, I know there's been attempts in the past with our Medicaid program to apply for 1115 waiver, you know, which is, I mean, they engaged in that planning, which is a creation of the uncompensated care of the federal Medicaid waiver program that would enable healthcare services to uninsured American Indians between the ages of 19 and 64. I just want to know a little bit of the history, what that requires, what that looked like, and is
Testing,
there
1, 2, 3.
future attempts of that going forward? Thank you.
Thank you, Representative Clifford. I think that I remember when that waiver discussion began. I think that is perhaps still swirling unaddressed in Washington, D.C., but I'd be glad to hear from the department on this.
Chairman Wilson, I'll try tackling that. Representative Clifford, and hopefully Terry can correct if I'm wrong, but we applied for that a couple of years ago. 1115 waivers are really solely at the discretion of the Health and Human Services Secretary. There's no real appeals or judicial process where the state can really force them through. We had the same experience with the air ambulance waiver we did. The 1115 waiver we applied last year, I think, or the year before, 2 years ago. In that one, we pressed and we eventually got a denial, outright denial. But with respect to the 1115 waiver for the tribes, it just has sort of gone to this limbo, for lack of a better term, where we just don't hear anything, and we can keep pressing on CMS and they keep responding, oh, we're still looking at it or considering it. But it's just because it is at their discretion, really. It's nothing that the state really can force through per se. And Terry, I don't know if you have anything else to correct me.
Madam Chair, the most recent meeting we had with CMS was, I believe, in January this year, and it did involve our congressional delegation. And I cannot remember if we had members from the tribes on that call or not. However, they did promise us some feedback. The person that represented CMS on that call is an interim director and received that promotion or new position under the new administration. And since that time, we have not heard back from them.
Madam Chairman, I have one more question, follow-up question.
Representative Clifford.
And if this Medicaid 1115 waiver would go through, how would that affect, I don't know if it's correct in me saying the FMAP or the reimbursement rate? What would that reimbursement rate be? How would that be a benefit to the state or not?
Ms. Green, do you want to take on that or Ron?
Chairman Wilson, Representative Clifford, I think, so in the absence of the 1115 waiver going through, the state Medicaid has worked with the tribes to, I wish Lindsay were here. She's now at DFS, but she and Amy would probably be able to talk to this significantly about the 638 providers. Is that what the term is? But we've significantly increased reimbursement rates at 100% FMAP for a lot of tribal facilities on the reservation. And so there has been a significant influx of entirely federal dollars, even in the absence of the 1115 waiver. So we're not sure that the 1115 waiver at this point would make too much of a difference just based on that significant influx in recent years, if that makes sense.
In addition to that, Franz, I would add that in the 638, the 100% match applies to anyone in the 638 that's covered by Medicaid. And that can increase the state cost because there are non-natives that are covered in those facilities.
Terry, could you just, what is the 638 that you're mentioning?
The 638 is a facility by definition. It's a federal definition that allows for tribes to use that as an extension of the same type of definition that an IHS, an Indian Health Services, receives.
So are you saying that currently, I guess I'm not quite following this, is the federal government is paying 100% for all care provided through these facilities, whoever the recipient? I assume they have to be Medicaid eligible.
Madam Chair, I do not believe they have to be Medicaid eligible to be in a 638, but anyone that's covered by Medicaid that's in a 638 is being paid at 100%.
By the federal government.
No, I said that wrong. Anyone that's in a 638 facility is being, if they're a Native American, they're being covered at 100% by the federal government. If they're non-Native, they're being paid at the rate, at the 638 rate, but it's 50% state general fund for non-Natives.
So were you saying that there's some concern that if the 1115 waiver actually went through, that we might lose the 100% FMAP for the Native population in those facilities?
Madam Chair, no, that wouldn't be correct. We're not losing the 100% FMAP on the Native Americans.
Okay.
Madam Chairman, I would suggest we get more clarification on this. I know there's two conversations going on. I did pop into the Revenue Committee about the Medicaid expansion, but our CEO of our 638 facility here, which my understanding is that the tribe manages it. We still get the allocation from the Indian Health Service dollars, which has always been underfunded here because we're in a region with Montana and all the Montana tribes. So we've historically only been funded at 34%. And so I think we need clarification as far as a 638 facility, but what we're talking about is an Indian Health Service beneficiary where I qualify as an enrolled member or somebody that can prove descendancy. And I just think we would probably need more clarification than that. And with Rick Brannon that testified the other day, I think we just need better clarification on how that all works. Thank you.
Isn't the healthcare issue on the Tribal Relations Select Committee's interim topic this year?
It's down there. It's not one of the top priorities, but it's on the list. We'll see if we get to it. Yeah.
Okay. Well, let's set this aside, and Terry, we might just ask for a little bit of, rather than tie up the whole committee on this somewhat, I don't want to call it obscure, but it's got a lot of acronyms and things in it. We could maybe do this we'll follow up and we'll see where that conversation should go. Okay, more questions. I can't see everybody's hand, so just shout out if.
Madam Chairman. Madam Chairman.
Representative Flitner.
Thank you, Madam Chairman. Just diagnosis of acquired brain injury, if I could get just an explanation of that. And then if that is a work-related injury or say military service related injury, what is the overlap with those agencies, say workers' comp and the military department? Thank you.
Department.
Chairman Wilson, Representative Flintner, I can take an initial answer at that. We might need to follow up with some additional detail just to be sure we're getting at every component of that question. First of all, again, Medicaid is the payer of last resort, of course. So if there were some obligation, let's say through military service, workers' comp, obviously that's information we would be cognizant of. As my colleague mentioned earlier, acquired brain injuries are diagnosed over the age of 21. Again, any acquired brain injury obtained under that age would be considered a developmental disability. So in terms of our programmatic functioning, similar to what Franz showed earlier on the eligibility component, that's where we have essentially that clinician information similar to the developmental disability diagnosis, certifying that information, as well as the level of care assessment of the LT 101.
So thank you. And Madam Chairman, just a follow up then. So for instance, if it was work related or military related, would we not see that data then if those agencies were funding that care? I'm just curious if there, you know, the number of injuries if versus payment, if that's the data that we're looking at.
Pardon.
We do try to match the same
Okay.
on injury or with workers' comp on injuries. I can't speak to them.
Okay. Yeah, I can.
Sorry, Madam Chair and Representative Flitner. So our agency does a cross match in terms of the unemployment, or excuse me, workers' comp information. However, I don't think we could speak to any similar cross match in regards to military at this time. But again, if we can follow up perhaps with some additional detail, I'm sure we can do a little bit of a deeper dive there for you.
And Chairman Wilson or Representative Flitner, I just add that Medicaid more broadly has a pretty sizable what's called third-party liability or TPL function. And so there's people that, you know, we devote a significant amount of effort to really identifying other insurers more broadly, whether it's automobile or other health insurance or other, you know, payers, because Medicaid truly is the payer of last resort. So that kind of would fit, I would imagine, for at least medical claims, kind of fit into that TPL type function of trying to identify other pay sources that would be responsible for that primary, if that makes sense.
I was going to say, I would hypothesize that the VA probably does some similar work case management with people that come to the VA with an acquired brain injury, as far as, because, you know, I'm not sure, and I'm just shooting from the hip here, but I think there are probably some services that are not necessarily available, or that, you know, I mean, so they but I don't know. I'm just imagining based on people that I know at the VA, which is, anyway. Okay, did you have a follow-up, Representative Flitner? Okay, any more questions from anybody else? Again, I can't see your hand, so just feel free to speak. I only see 5 people, and I'm sure more of you are there. Okay, well then I guess that is all the questions. If that's all the questions that we had about, let me just see if I see any last. Good, I'm glad to see it looks more. All right, then we're a little early. That might be the first time in the history of the Labor Committee. We're going to actually take our break now then and not come back until 10:45 for the Title 25 overview, just so that people who might have set their schedule specifically to come for that don't show up partway through. So you will all have a half-hour break and be back, please, at 10:45. Thank you. We seem to mainly be back. Donna, are we set to start again? Or are we, I guess we're live anyway.
Yes, we are live, Madam Chair.
Okay. Franz, are you going to do the Title 25 or someone else?
Madam Chairman, the other Franz will be doing it. This is Stefan. I'm so happy to give an overview of Title 25 whenever.
No, the other Franz is Hans. Franz.
It's my nickname in many circles. So happy to start the overview whenever you're ready.
Very good. Go ahead.
Thank you, Madam Chairman and members of the committee. Stefan Johansson, I'm the Deputy Director for the Department of Health. I just want to thank you and the committee members for having us give an overview of this topic. It's something that we and I personally have been working on for really the better part of a decade in terms of Title 25 policy issues and improvements. I will mention at the outset that this overview is very, very general. I think it's meant to be general, but like all other aspects of the Department of Health, Title 25 is a huge system and a huge policy issue that it literally involves almost everybody you can think of in state and local government. So Department of Health, law enforcement, county attorneys, local providers, hospitals, the state hospital, it really, mental health providers, it really runs the gamut of one of those issues that really touches almost every sector of state and local government. So apologies in advance that this presentation is quite broad, but happy as usual to follow up or speak offline with members of the committee on specific, Title 25 questions or issues, or try to answer them during this presentation.
And again, just to say, committee, we'll go ahead. If you could just mark your questions, identify the slide if possible, and that way we'll just take them all at the end, I think. Go ahead, Stefan.
Thank you, Madam Chairman. Members of the committee, the agenda today for Title 25, again, we'll give a very, very high level overview, get into a bit more detail on how reimbursement from the department works in terms of that process that governs Title 25 when the Department of Health gets involved, which is at a certain stage of the Title 25 commitment process. Talk briefly about a few opportunities or initiatives that are actively being worked on currently, and then wrap up with kind of an overview and an update of Title 25 data. So without any further ado, I wanted to present this slide. It's a visual that we've used in years past, and it really is kind of both my personal kind of perspective, a visual that helps me, as well as something that kind of gives an overview of
Hello.
Madam Chairman, this really shows in a very oversimplified form kind of the continuum of care in mental health, primarily as it relates to higher levels of care and legal systems like the Title 25 commitment system. Starting on the left, when you think of some of individuals in our communities that might have behavioral health needs or might end up in certain levels of care or systems that the state offers or that local communities offer for mental health services, you kind of start on the left, at least in my mind, with kind of prevention and community treatment that's available. So that runs the gamut from public health prevention, efforts and initiatives that our public health division and our counties really operate and provide, as well as different types of coverages for services that might be, for lack of a better term, pre-institutional, and that includes Medicaid coverage. Medicaid coverage through various waivers, like we talked about this morning. We have listed here the care management entity, which is closely related to the children's mental health waiver, providing mental health coverage, preventive services, et cetera, for kids. And then maybe the biggest kind of player in this from a state funding perspective in this part of the continuum would be your community mental health and substance abuse centers. So both in terms of treatment as well as their participation in Title 25 through gatekeeping roles, which we can talk about in a bit more detail later in the presentation. In addition, we do have kind of attached to the legal system a program called court supervised treatment or drug courts that really provide sentencing alternatives for folks who might have mental health and substance abuse issues that have committed crimes and are able to agree to treatment as an alternative to sentencing or going to jail. Moving on the continuum, kind of in the middle here, is what I like to think of as your hospital or institutional levels of care. So folks who may be in the first part of this continuum or the first bucket, but decompensate or have an acute crisis or need some more support or may be dangerous to themselves or others, can enter kind of these higher levels of care, sometimes through the Title 25 process, and end up or receive treatment at the state hospital, both on the civil side or the forensic evaluation side if there's criminal charges, as well as other kind of inpatient psychiatric stays that happen through designated hospitals, which we'll again talk about here in a bit more detail. We also have, as we mentioned this morning, psychiatric residential treatment facilities for youth. Again, when youth or adolescents, kids need kind of a higher level, an acute or more institutional level of care, stabilization, et cetera, for behavioral health needs. Kids will sometimes go to or receive treatment at PRP. And then finally, I think it's worth mentioning that the Department of Corrections certainly has a role in this continuum. As we know, a lot of the populations that are served through these various systems sometimes do encounter the correction system either on the way in or on the way out. And then on the right side of the chart, Madam Chairman, you can really see, kind of similar to the first bucket, what we like to call your community step down or aftercare. So folks that may be coming on the tail end of an acute crisis or a civil commitment, really, needing continuing supports or intermediate supports in the community. So again, would reference the community mental health system, both in terms of outpatient and residential treatment, as well as hospital discharge planning, various types of outpatient commitments or convalescent leave from hospital level of care often involves our community providers. And then again, would just highlight that for a select, few, I would say, of the types of populations we see in this continuum, some can qualify for various levels of Medicaid coverage, like we mentioned this morning, depending on both their financial assets or income and certain categorical eligibility criteria. And then kind of underpinning all of that for the purposes of this discussion is really the legal system. And so both in the kind of preventive and in the hospital and the kind of community step down care, a lot of individuals that we see in our communities do go through some of these legal systems, whether it's Title 25, Title 7, court supervised treatment, corrections, legal custody issues with Department of Family Services for higher needs kids. It really does run the gamut, and the behavioral health continuum of care, as it were, is very broad, and this is really only a piece of it when we talk about Title 25.
Right. And Stefan, I'm just going to insert something there, and specifically because we are committee focusing on the Title 25, this is necessarily, these colored boxes are basically focused on state type situations. Obviously, the mental health services, there's a whole private sector of practitioners who provide mental health or substance abuse services to people, private hospitals, people who have insurance are able to access those. We've got suicide hotline and all sorts of, private and nonprofit type groups that provide care. So we're not meaning in any way to dismiss their part in the whole panorama of the services that people get, but because this presentation we're focusing more specifically on Title 25. So I just wanted to make that comment. Go ahead, Stefan.
Madam Chairman, excellent point. Would totally agree with that. Moving on to slide number 69, just kind of an overview. Who are Title 25 patients? And just kind of by way of introduction, Title 25 patients, as you all probably know in interacting with your community and various stakeholders of behavioral health, these are individuals who are deemed through more of a legal process to be dangerous to themselves or dangerous to others. Common situations or behaviors include suicidal ideation, self-injurious behavior, violent or threatening behaviors, or the inability through the eyes of a court, the inability to provide basic care for oneself, really due primarily to behavioral health needs or acute psychiatric needs. The first encounter in the Title 25 system is often law enforcement or emergency departments. So a good way to think about it is when someone in one of our communities experiences more of an acute behavioral health crisis, it's often law enforcement that's responding to a call, whether it's from a family member or a neighbor or a retailer, or someone presenting at a hospital in an emergency department, presenting with kind of acute psychiatric symptoms that, per definition of the law, when the process starts, someone deems initially this person may be a danger to themselves or a danger to others. That's really, again, overly simplified here, but really what starts the Title 25 process. And how on slide 70, you can kind of see, again, very, very rudimentary description here of how the commitment process works. And kind of following statute, if you look at Title 25, Chapter 10, is really where this is all governed strictly from a legal, state statute perspective. The first part of the process within the initial 24 hours is what's known as an emergency detention. And so again, whether it's law enforcement or whether it's an emergency room physician or some intake at a hospital, that process generally starts where someone says, okay, this is acute enough where we're concerned about the safety and well-being of the person or others based on the person's condition or behaviors. And there's a whole process that governs what has to happen in that first 24 hours where an emergency detention can be made. Those of you who liaise with your various stakeholders, county attorneys, et cetera, might recognize the term a 381 form. That's really what county offices use to start the filing process of the Title 25 on one of these patients. And essentially what that does is allow the hospital or law enforcement to detain a person for up to 24 hours before a hearing is conducted in front of a court, in front of a judge. So oftentimes that report will be filed and taken, the county attorney will file it, and then a judge will determine through a hearing, does this individual's condition or situation warrant what we call a continued detention? And just referencing statute, that kind of starts in what you might have affectionately heard referred to as a 109 hearing. And that just refers to the section of statute that governs a continued detention. What that means, Madam Chairman and members of the committee, is the ability for that community, that county, and thus the provider hospital to hold a person for now up to 10 days. So it continues that 24-hour process for an additional 10 days, pending what is ultimately another hearing, which is the involuntary hospitalization hearing, or what is referred to as a 110 hearing. Again, just governed by the section of statute 2510-110. And that's where kind of the ultimate process of Title 25 culminates, is in a judge's decision, kind of in step 2, do we continue the detention? And then in step 3 is an involuntary hospitalization order warranted here, which formally, civilly commits a patient to the custody of the state and specifically to the custody of the state hospital. So those 3 processes, it's again, oversimplified here, but it's easy to think about this as kind of a somewhere between a 1 and a 10-day process from beginning to end. Now that often is longer because of weekends and legal holidays, which are kind of accepted in statute. But it's really, a 1 day to a 2-week process. And often folks who go through the Title 25 commitment process essentially are not committed. They are stabilized at the emergency department, either during that 24-hour period or during that 10-day continued detention period, or frankly, in many cases, a mental health assessment that's required to be conducted in that first 24 hours. A professional might deem this is not a Title 25 case. this person is not danger to self or others. And referral to treatment can happen. That's where we like our gatekeeping system to be as robust as possible, which we'll touch on a little bit later. But really that, the process can vary depending on the individual, depending on the attorney's office, depending on the provider, and depending on what resources are available either locally or at the state hospital. So the Department of Health involvement in Title 25, really in the legal process and in our financial responsibility, it really begins or starts in steps 2 and 3. So in statute, there's an important distinction, somewhat arbitrary, but legally speaking, an important distinction between the first 72 hours of treatment or commitment and post 72 hours. So in 2510.112, it really governs whose responsibility is it in the early stages of the commitment process. And in those first 72 hours, plus weekends and legal holidays, it's really the kind of jurisdiction and financial responsibility of your county attorney's office, your county government, that both is responsible for payment of services, as well as obviously in the legal process, which they are part of the whole way through, a big involvement from the county office. The state really takes over financial responsibility just to pay, for folks who are in a hospital or, for example, at a designated hospital like WBI or Cheyenne Regional, any hospital that has psychiatric beds, and there's a Title 25 process underway. The department will pay for those services strictly from a financial standpoint after those first 72 hours have expired. Our involvement obviously increases from more than just a financial component to more of a service delivery and treatment component when individuals might escalate through Title 25 and be committed to the state hospital. In addition, Madam Chairman, there is a distinction in statute for financial responsibility for in-state versus out-of-state residents, where that first 72-hour rule of county financial responsibility, it does not apply for out-of-state residents. So if there's an out-of-state resident who goes through our Wyoming Title 25 process, the Department of Health, our department, is responsible for those costs of treatment, transportation, et cetera. And then finally, a distinction between county of residence and county of detention, kind of a hotly debated topic in Title 25 law and policy in Wyoming, where the statute does govern this of who is responsible for certain costs, county of residence of the patient or county of detention, because as you all know, that can really vary with transient populations or folks who are committed, but the resources in a bordering or another county. And that, I think there's some legal nuance there, and also some disagreement and some discrepancies on who is responsible for what, that I know the Judiciary Committee last interim and this interim is discussing again for potential clarifications in statute. Slide 71, Madam Chairman, again, getting into more of our process in reimbursing for Title 25 costs. Just wanted to point out a few changes that were made relatively recently, where prior to 2016, designated hospitals and providers in all of your communities in those, kind of post 72-hour periods of commitment prior to a patient going to the state hospital, we were paying for those claims and reimbursing for those claims very manually at the state hospital. It was quite burdensome. And through the work of a Title 25 task force with the legislature back in 2015 and 2016, the Department of Health really administratively cleaned a lot of that up. And similar to what we were discussing before with the implementation of the new eligibility system in Medicaid, we tried in Title 25, and I think successfully, to leverage Medicaid technology and infrastructure for Title 25 to really make this easier and make it more rules-based and make it less administratively burdensome. And so since 2016, all claims for reimbursement from the Department of Health for Title 25 costs basically run through our Medicaid system. It doesn't necessarily mean it's for Medicaid eligible people, but we use the technology to have hospitals and providers submit claims, determine what claims will be paid based on the law and based on our rules, as well as something that Franz was mentioning earlier, that we are able to leverage a really good component of the Medicaid infrastructure in third-party liability. So often a provider, by no fault of their own, may not know that a Title 25 patient in their care has a pay source, a private insurance or Medicare or TRICARE, VAs, things that might reimburse for these services so that the state general funds could be payer of last resort. And we've noticed quite a bit of efficiencies by nature of leveraging that technology.
Stefan, I just want to, and my apologies, I told people we're not going to take questions, and this isn't a question, I'm just clarifying. But so to be very clear for the committee members, most of these patients are not Medicaid patients. You're just using the Medicaid computer system to do computer things for these people, billing for these people.
Madam Chairman, that's largely correct. It was, I think, a good move, both in terms of finding those potential private pay sources if they're there. You're right that the large majority of these Title 25 patients do not qualify for Medicaid, but a certain fraction of them that we've noticed since 2016 do or have been on Medicaid or are on Medicaid. So we've been able to, again, really make that payer of last resort for the state funds work a little bit better. But you're absolutely right. Demographically speaking, the large majority of these patients do not currently qualify for Medicaid. So we just use the technology, as it were. And another benefit of this system is really since 2016, which you'll see later in the presentation, it has allowed for more longitudinal data collection, at least on the state side, kind of that post 72-hour period when the Department of Health really enters the game of Title 25, and we're able to look at demographics of the population, look at services received, look at other programs or Medicaid eligibility, like I mentioned, that might be there. It's certainly not perfect. This is a difficult population to track or to discern outcomes on in many ways, but it has greatly improved our ability to essentially know what's going on when the state is paying for services in Title 25. And in terms of eligibility that we run all of these patients through, it's still quite a manual process because this requires kind of high touch, review of documentation like those court forms or demonstrations of residency. It's not as automated as a lot of eligibility processes are in traditional Medicaid. And we really have to throw a thanks and a kudos out over the past 5 years to Terry Green and her staff, who really just kind of dove on this grenade when we said, hey, this could really benefit our data analysis, our data collection, as well as our claims processing process. And they really, Medicaid really helped us out. It's not really a Medicaid required function, but they've really done an excellent job helping us, process all of these claims as well as determine eligibility for folks. Madam Chairman, in terms of some opportunities that are tangentially or directly related to Title 25, I always see Title 25 as really the legal culmination of the potential need or utilization for a higher level of behavioral health care, or in many cases, the highest level of behavioral health care when you go to the state hospital. We do have some opportunities on the horizon that are underway. And as many of you know, going back to the work of a joint executive and legislative task force that was established in 2014, we have been constructing a brand new state hospital facility and a brand new life resource center facility with kind of new missions, where the state hospital on the civil side is really geared towards acute stabilization, treatment, and discharge of Title 25 patients. And the reason I bring that up, members of the committee, is in when we did the analysis with the task force years ago, one of the biggest problems in that kind of affects you all and your communities kind of downstream is the wait list that we've historically had at the state hospital, primarily related to the fact that we have a lot of long-term patients who we are unable to discharge that have been essentially occupying short-term beds. And those are patients that the private sector, nursing homes, et cetera, are either unable or unwilling to accept based on their conditions, based on liability. And it's important to think of that as kind of, geriatric psychiatric clients who may be in the state hospital literally for decades. They're certainly have behavioral health conditions, some violent behavior, but their primary needs are, more skilled nursing. But we struggle to find placement in private nursing homes. And so this was really one of the biggest components of the redesign of the two facilities, both in Evanston and in Lander, is to help decompress the state hospital by serving those clients in a more appropriate skilled nursing setting at the new Life Resource Center. So that will greatly increase capacity of the state hospital. And like I mentioned, downstream or upstream, depending on how you look at it, in your communities, you've probably often heard of the time it takes to get somebody into the state hospital or the resources that aren't available for certain types of populations. And we're really excited that we're reaching kind of the culminating end of that facilities project to hopefully improve that continuum as much as we can, open up beds at the state hospital so that the process flows much more smoothly in our communities, especially in the Title 25 process. We did cut the ribbon at the state hospital last August and moved patients into the new facility between September and October of last year. And the Life Resource Center, we anticipate that project to be complete, hopefully by the end of this calendar year, which will kind of result in, again, the culmination of a lot of hard work by the legislature and by the department to reconstruct and remission these facilities. The other opportunity, Madam Chairman, that I would mention is very recent. So in this last session, you all passed House Bill 38, which became House Enrolled Act 56, essentially a community behavioral health redesign. And if you think back to the slide that I started with, it kind of overly simplified but visualized that continuum of care, kind of pre-institutional, institutional, and then step down or community care on the tail end. This continuum all kind of works together. So when we finish the state hospital and the Life Resource Center, our practitioners at the hospital, our psychiatrists, psychologists, nurses, et cetera, as well as likely health practitioners and behavioral health folks in your communities would agree. The next step is, how do you connect populations like that to community resources? How do you keep folks in their community, kind of from an Olmsted perspective, in the least restrictive and most therapeutic community-based alternative to institutional care? So we see House Enrolled Act 56, this bill that you all worked so hard on and passed this previous session, really helping us connect our community providers to some of these priority populations that we see ending up in other state systems like Title 25 in the state hospital, the correctional system, the DFS system for high needs children and families, as well as acute psychiatric populations, those with severe mental illness, and certainly indigent clients with very low income who may have behavioral health needs. We really see this defining, the state policymakers, you all defining our mission for this system and prioritizing these populations as potentially a huge benefit to this entire continuum, where we can really kind of make these systems, hopefully make these systems work together and provide the most comprehensive array of services for this population to avoid these higher levels of care that are both, bad on the budget as well as often bad for outcomes. We see recidivism in corrections, for example, and I think this bill is a really good opportunity to reduce that reliance on institutional care. So that is in the process of being implemented. We've started a steering committee with a few legislators as well as a stakeholder group and various work groups that have kicked off in the past couple of weeks. And we're excited to do that initial work, designing some concepts over the summer and report back to you all, I believe in September, on how that work is going. But a huge opportunity to kind of do more with less. And I know we're all trying to do that these days. And that prioritization of the populations who are most in need and sometimes underserved is really a huge new mission now for the Department of Health and our providers. Madam Chairman, moving on to kind of a data update on Title 25, you'll see here on slide 73 the number of involuntary hospitalizations. So think back to that, what I called the 110 hearing, so the final process of Title 25. If a court and a judge decides that a person should be involuntarily hospitalized, that puts the person in the custody of the state hospital, where as quick as we can, that person would be admitted to the state hospital for treatment and stabilization. You can see from 2012 to 2016 a pretty linear growth in the number of involuntary commitments that were happening statewide. That was really the genesis of that task force that I mentioned that studied this issue related to Title 25, because we were seeing so many more commitments and thus a huge growth in the state costs related to paying for those commitments, given the wait list at the state hospital. And you can see after 2016 and some of those reforms, the reduction in the number of involuntary hospitalizations for various reasons. Some of the administrative things I mentioned with systems and processing claims and getting a bit more knowledge of what was going on, I certainly played a role in that, as well as various community reforms that happened, gatekeeping being for lack of a better term, assigned to some of our community providers to really case manage people through the process, find alternative levels of care that might, where we might not need the state hospital or designated hospitals to provide that care. And I think that's been a slow but a very successful and hopefully improving process over the past couple of years. It's not always stakeholders that you'll talk to are not always in agreement that Title 25 is in a good place. I would concur with that. There's always room to improve, but it's worth acknowledging both at the state and the community levels the improvements that have been made over the years to make Title 25 work better, but also reduce the state's reliance on institutional levels of care. Same data here, Madam Chairman. I know a bit of an eye chart. I really just want to point out to the committee the kind of granular level at which the state and the department tracks our involuntary hospitalizations by county and by year. And again, happy to follow up with more detailed reports or information if anybody's interested. You can see we've color coded them, again, going back to this chart with that linear growth and the number of commitments. You can kind of see color coded where you're just in raw numbers. This is not a judgment call on any community, but where your commitment volume is larger. And you can kind of see that in the color coding going up to 2016 and then kind of stabilizing, coming back in the other direction from 2017 to today. Wanted to show this chart here again, just for one reason, just to show again how our implementation of that new system and that new process for paying for Title 25 claims really does bolster our ability to track longitudinal data. So what you see here is really, kind of the number of Title 25 episodes broken out by the disorder that we see kind of logged in the claims data. And you can see kind of it goes without saying that bipolar disorders, depressive disorders, and schizophrenia spectrum and other psychotic disorders really represent the lion's share of what we see in the claims data for Title 25. And again, it kind of goes without saying, right, that other types of conditions, maybe a court or a judge determining that someone's unable to care for themselves, but the diagnosis might not be there. Those certainly happen, and you can see that in the bottom left portion of your screen. But for the most part, what we see in Title 25 involuntary hospitalizations are largely these diagnoses that that typically generate the types of behaviors or conditions that that result in civil commitments. And Franz, I know you made this chart. You make all of our pretty charts. If there's anything you'd like to add.
Sure. It's just some of these charts are not as intuitive as others. I think it's just, these are what we're looking here is basically counts, like the frequency of the episodes. And I think that what's interesting, I guess, of this is looking at the age. The bulk of the age is usually between 20 and 50 or so. It seems to be kind of the bulk of the age. Men tend to be a little overrepresented in this data, particularly when it comes to the schizophrenia spectrum. You can see the lines there, the blue line kind of being higher counts than for women across the board, whereas for bipolar and depressive, it's less of a difference. But those are just kind of some interesting facets. I'm not sure what you do with this information. It's just sort of interesting to look at. I think obviously we have to have this cutoff at younger ages because when kids tend to go through the system, there's some random outliers there like that 0 to 5 on the bipolar, which is probably maybe a claim mistake, but kids would generally be under Medicaid and would not be covered by Title 25 in these institutions. So that's kind of an artifact of just what we're paying for is really adult services under Title 25 with state general funds. So that's why the bulk of the distributions kind of start around 20 years old or late teens, just for that reason.
Thanks, Franz. And Madam Chairman, moving on to slide 76. This shows now we're at the state hospital and wanted to give you a sense of what we track literally on a minute-by-minute basis. Our data over the years has become very granular. But you see here in any given day or week, kind of our state hospital, the civil side of our state hospital, broken out in these different categories. So on the bottom, you can see our long-term patients. So those, and this is just kind of a way we carve up the data. That dark blue bottom section here really shows our patients who have been at the state hospital for greater than 180 days or 6 months. And that goes back to what I was mentioning before, where you can see we have been making progress and there's more to do. But with the facilities task force and the reconstruction projects, the idea is to shrink this these long-term bars down here by nature of opening the new Life Resource Center nursing facility for these types of patients, but also kind of refocusing or re-emphasizing the state hospital's mission as an acute care facility for stabilization, treatment, and discharge. So the more this population at the state hospital, which is kind of an artifact of history, you can see it's been kind of coming down. There's more work to do. The idea is to shrink that so that this middle section, this light blue, which is our short-term clients, so that could grow, and that the beds that we have at the state hospital on the civil Title 25 side should be really set up to serve your communities, to serve folks who might be at that higher level of need, go through the Title 25 process, get a civil commitment from a judge, and then have a quick entry or admission to the state hospital. Hopefully, within reason and within safety, have a relatively short stay at the hospital, be stabilized, get treatment, therapies, social supports aligned, and then discharged back to the community care, community providers. Again, going back to the importance of House Bill 38, House Enrolled Act 56, that those clients would be prioritized for kind of continued treatment, social supports, et cetera, in their communities. And those two categories, this dark blue and light blue, your long-term and your short-term patients at the state hospital, are all impacted by this yellow kind of volume here, which is our wait list. And you can see it fluctuates over time. A couple of years ago, we actually had our wait list at 0, but it's all, it's kind of a dynamic, and think about pushing on a balloon where if you have kind of an increase in volume of commitments from counties and from communities, that will impact your wait list, which is also impacted by, the volume of clients and the type of clients we have at the state hospital. So you can kind of see it as a dynamic that if we have long-term patients occupying short-term beds, if we can decompress that and serve those patients in a more appropriate setting elsewhere, then we can shrink this wait list and therefore provide better customer service to your communities, to your county attorney's offices, to your courts, as well as, more importantly, to clients who we want to make sure go through the Title 25 process, if necessary, as quickly and most effectively as possible. And so you can see, I think the state hospital has done an admirable job, especially during COVID, which really threw a wrench in everything, because we had to completely change the physical plan of the state hospital with various protocols, admissions units geared towards, isolation, testing, all of those kinds of things. So we've had some challenges, but you can see the kind of, if you just put your fingers, and measure the band of this yellow section, you can see it, hopefully shrinking over time. We've seen some growth recently by nature of some commitments we've had. But once we open the Life Resource Center, we're really hopeful and optimistic that we can dramatically shrink that wait list, which again provides better service to our communities, and in addition should be a financial benefit to the state, because we'd be leveraging more of our fixed costs at the state hospital as opposed to paying for those services due to the wait list in designated hospitals or emergency rooms, for example, where we pay for those services and that treatment while someone's waiting for admission to the state hospital. Just to give you a summary, Madam Chairman and members of the committee, of our Title 25 costs, again, you saw this in previous slides based on the number of commitments. That growth is kind of directly correlated to the growth in commitments is directly correlated to the cost. So you can see going up to the 2015-2016 biennium, where we hit over, it was slightly over $18 million in biennial Title 25 costs. At the time, I think we had a $4 million budget. So again, you can understand why the legislature and the governor at the time said, we need to study this. We need to get our arms around what's happening here, because that cost growth was just so extreme. And you can see that coming down in the recent biennia, where in this current 21-22 biennium, we're projecting around $9.1 million of Title 25 costs, which is within our budget that's currently a little over $12 million for the biennium. So that has come down. Again, we're not totally just focused on costs, that Title 25 improvement equals reducing costs. That's obviously not the case. The department's focus is primarily on serving these patients when they're in our custody as best as we can, and working with our providers to do that. But it's certainly an important component of the system, because it drives so much of what we are able to do for these patients, if we can live within our budget and live within our appropriations. Madam Chairman, I'm going to move to Title VII. I know the presentation is about Title 25, but Title VII is an important related system here, because it does interact with the state hospital and similar populations. But Madam Chairman, if it's your pleasure, I'm happy to stop to answer questions or just move through the presentation.
Do we have specific questions from the committee on about the material?
Madam Chairman.
Representative Flitner.
Thank you, Madam Chairman. I just want to clarify on with regard to the reasons that you took a look at this was that, from that spike in 16-17 on slide 73, and then you spoke about what derived from that study, and basically reforms and systems were changed, processing claims, community reforms with a gatekeeper system. So all of those elements were drivers then with regard to slide 77, where it shows this great cost reduction. I hope I made myself clear.
Madam Chairman, Representative Flitner, yes, that's an excellent summary. And not to put words in your mouth, but I think what I heard, and I totally agree with, is it wasn't one single factor that led to the cost decreases. It was really, like I mentioned before, this is a legal system that involves so many aspects of state and local government and various programs and providers and stakeholders that it really was a lot of different kind of effort that put attention on Title 25 commitments rising and cost rising and what we as the state and what communities could do about it. I think that kind of Hawthorne effect of when you look at something hard enough and communicate about it long enough, you start to see some changes happening. And it's certainly not not perfect, but I think you're right. A lot of those efforts that are still ongoing in many ways. A few of them I mentioned with the facilities and the community behavioral health reform that's now underway, all kind of have an impact on what we see in the Title 25 data here.
Thank you.
So, Madam Chairman, just a few.
I see some more hands. Representative Connolly.
Thank you, Madam Chair. Because my question, I believe, is on slide 75. And yeah, this one here. And so I'm curious, two questions on this. How is our data similar or different than other states? And then I'm curious if we have looked at this kind of data and have targeted programs. So for example, I mean, I would assume that involuntary hospitalizations are the absolute last resort. We don't want that. And so do we have targeted programs, for example, to men, where we're seeing, incredible spike, it looks like, of men who are middle-aged needing involuntary treatment. So I'm curious about, or involuntary hospitalization. So I'm curious about treatment before that would happen.
Madam Chairman, and Representative Connolly, it's great questions. I'll take them in order. In terms of how we compare to other states, we did look at that with the task force years ago. And I hate to throw a wet blanket on it. It's very difficult because there's really not a comprehensive data source or standardization across states in how they track civil commitments. There are studies out there, which I'm happy to kind of dig up and send to you that try to look at rates of commitment, but the data sources are so disparate that it's really hard to get an apples to apples comparison. But there are some resources which I'm happy to share with you. In terms of kind of services that are targeted specifically to different types of demographics, I would say that when an individual reaches, for example, the state hospital, the answer to that is yes. We have different treatment modalities for different types of folks, whether they're age dependent or gender dependent, or depending on what types of social circumstances or history of trauma they may have had. But I think the spirit of your question, and feel free to correct me if I'm reading too far into it, is really in our communities, are we geared towards providing preventive services that can target these types of populations or conditions? And the answer to that is yes and no. Yes, in the sense that we do have networks of community providers that can provide services tailored to an individual's needs. And then no, and I'll say not necessarily no, but room for improvement going back to the bill that passed recently, where I think that's really the heavy task for the department and those community stakeholders and providers, is to determine how can we do that better? How can we target those services to these individuals in a way that not only provides them their necessary treatment services, but also what we all know, and we all know is so difficult, provide social supports that aren't necessarily therapy services or medications, but those social determinants that we know are so impactful to this type of population, like housing supports, employment supports, in addition to health insurance. That's really what we're working on, to try to find the best system and the most reasonable system to put our hand on the scale in partnership with our providers to not only pay for treatment services, but start to connect these systems where those different elements of our societies can start talking to each other. We know that employment, education, income, housing have such a huge correlative impact on behavioral health populations and their outcomes. And that's really a lot of the work we're trying to do over this interim period with our providers.
And I think just to insert in there, you know, when you look back to the whole deinstitutionalization movement in, I guess it was in the 70s, but, you know, the overlap, sadly, between the homeless population and the people with mental illness, especially that schizophrenia and other psychotic disorders category, is really significant. I think, and I don't remember, you know, it seems to me that 60–70% of the homeless population, I maybe have the number wrong, but has underlying mental illness. So it's a very difficult population to capture. Not that doesn't mean that we shouldn't try to capture, but but that's been part of the discussion, you know, with community mental health services for some decades now, is just sort of the negative consequences of deinstitutionalizing when you haven't really got as many services as you would like to have. And I see Representative Hallinan has been
Madam
waiting.
Chair,
Oh,
if I may
follow up then.
Yes, it's a follow-up or a follow-up comment. Representative Flitner had us take a look at the dollar figure that has decreased significantly from 15–16, I mean by 50%. But what I am kind of concerned about is that, did we learn as well in terms of the kinds of services that are most needed? And my comment, because it's been talked about at least 2 or 3 times by the department somewhat favorably about the bill that was recently passed regarding priority populations, and certainly people in the House remember I had some concerns about that. But to me, that bill prioritize those who are justice impaired, and also in terms of recidivism, right? We want to prevent recidivism. We want to prevent, as opposed to what may be needed to kind of prevent involuntary hospitalizations. There was just comments about, employment and other services and community-based services. And I just hope, given the data that we just looked at, that really is a priority, both in terms of the health needs of our residents, but also in terms of our kind of obligations as a state. I mean, this data, I think, really points to that. And I do have some concerns about that bill, but I hope my concerns are wrong.
And I'll just insert, because Representative Connolly, I think 15–16 was your last term on appropriations. And you may recall that the way that appropriations funded the blossoming Title 25 cost was to tell the department to take it out of your budget, and they pretty much took it out of community mental health services, is my recollection. Perhaps Representative Connolly remembers that.
No, I would vote against that. However, okay.
Representative Hallinan.
Thank you, Madam Chairman. I would be curious to know, this is a fairly large population of folks that have been committed on Title 25. I'd be curious to know what the suicide rate is with that group compared to, say, the general population of the state. I wonder if that has been investigated at all. Thank you, Madam Chairman.
Madam Chairman, Representative
Interesting
Hallinan,
question.
Yes, very interesting question, Representative Hallinan. We don't have that information with us today. It's something we can look into. I'm not sure that analysis has been conducted with to basically match the information, the IDs and demographics we have for the Title 25 population with what's in our vital records data for cause of death. Something that we can certainly investigate and potentially report back to the committee. And Madam Chairman, if I may, I did want to address a good question from Representative Connolly about going back to that large review that happened with the legislature and the executive branch in 2015, 2016, looking at Title 25 and really, in many ways, improving our data collection, like you referenced, Representative Connolly, and to your question about knowing what types of services or supports that were really maybe contributing to that increase in state hospital admissions and stays and length of stays. I would say that a large portion of that, when we started to actively on a daily basis monitor and track our state hospital population, we looked at what are the barriers to discharge for these civil commitment folks. And more often than not, it was the things like we were just discussing that, again, it sounds so pedantic, I don't mean it that way, but it's things like stable housing, other social supports that might include, job training or employment, supported employment, health insurance, access to pharmacy, those types of things that aren't typically in your kind of behavioral health or mental health service delivery model. They are in some cases, but not generally speaking. And so not trying to be overly Pollyanna about House Bill 38, because it is a huge task and an endeavor to make that bill work and to implement it successfully. But that's a huge component of what we're trying to design to make it work, is to connect just the general service provision, your therapies, counseling, medication management, with those social supports, and what is the role of the state and the role of our community providers in helping us improve those social outcomes. That is really one of the largest barriers in the Title 25 system that we've identified, especially at the state hospital, that essentially keep us from more frequently discharging those clients, if that makes sense.
And Representative Connolly, that is one of the main reasons why I amended in to add case management into House Bill 38 as sort of a required component, because even if the state is not by itself providing all of those services, the need for case management in this population is really significant. So, did we have any other questions while we're sort of at this little pause here? Okay, go on, Stefan.
Thank you, Madam Chairman. We'll move on now to, let me see if I can, there we are, to Title VII. So like I mentioned before, just thinking about the structure of our state hospital, we have two units. One is what we call adult psychiatric services, or APS, and that's really your Title 25 civil commitment unit of the state hospital. Those are folks who have gone through the Title 25 process, not criminals, have not committed a crime, but it's really by nature of their behavioral health condition that they're dangerous to themselves or others. On the other side of the state hospital, we have what we call our Criminal Justice Services, or CJS, which really is our Title VII services. And so I'll get into some of the detail about the state hospital here in a minute, but I think it's worth asking and addressing who are Title VII patients. And again, this goes back to all of your communities. You're probably well aware of some of the work that your county offices, county attorneys, and courts and law enforcement do, where you've probably heard about Title VII or forensic evaluations or commitments. So Title VII patients or individuals are generally involved in the criminal system, and they may have behavioral health issues related to the crime committed. So again, think of behavioral conditions like suicidal ideation, again, injurious behavior, threatening or violent behavior, or inability to care for oneself, very similar to Title 25 type conditions, for lack of a better term. But the way that it works is when someone is a pretrial detainee or has been arrested or convicted of a crime through the legal system, you might see that that folks will plead not guilty by reason of mental illness, things like that, or an attorney, a defense attorney, or an appointed attorney might request a mental health evaluation to make that determination. So that's where in Title VII, Chapter 11, you can see governed adult criminal evaluations. And those are conducted primarily by the state hospital on an inpatient and an outpatient basis. The evaluation types that we see ordered by courts are competency to stand trial, A competency restoration may be after competency has been determined to not be there. What we call MSO, or mental state at the time of the offense, again, for various legal reasons that an attorney or a court, a judge might want to sort out. And then finally, guilty by reason of not guilty by reason of mental illness, or NGMI, and then various risk assessments that can be conducted for certain issues like how bail might be established, those kinds of things. Evaluators that conduct these evaluations may be called to testify at trial. And I just want to reiterate that courts will order inpatient evaluations at the state hospital, but we also provide outpatient evaluations where essentially we send forensic psychologists, forensic evaluators on the road to a detention center in a community, or to wherever a pretrial detainee or individual might be held, to conduct what we call an outpatient evaluation. Basically an interview and then a review of all of the evidence for a forensic expert, a forensic psychologist, to determine competency or mental state at the time of an offense, or a plea of not guilty by reason of mental illness. So who can conduct these evaluations? That's very specific in statute in 7-11-301, that a licensed psychiatrist, other physician with forensic training, or a licensed psychologist with forensic training can conduct the evaluations. In 7-11-301 and the subsequent Romanet, the statute governs that a court can basically ask or demand that the state hospital or another facility designated by the court that can adequately provide for the security, examination, or treatment of the accused can provide these services. Like I mentioned before, Madam Chairman, typically these services are provided by the state hospital. The point I want to make here is that as we look at, especially on the civil side or the community mental health side, various reform initiatives to do more with less, to get better outcomes, there is an opportunity here to bolster forensic evaluation resources that are available in communities. And it's something that, as Representative Connolly mentioned, with one of the priorities in House Bill 38 being defined as state or non-state justice involved, in addition to the acute psychiatric and DFS families that are prioritized in that bill, this is another one of those areas we will be looking at to determine how could we bolster or improve resources that are available more locally for these types of forensic mental health evaluation services? And is there a role for the state or our partner providers to begin building that type of infrastructure? Again, going back to the state hospital's role in all of this, like I mentioned, we have the civil side and the forensic side that's involved in Title VII and Title 25. So, Madam Chairman, it's kind of an abrupt, anticlimactic end to the presentation, but just wanted to give a very high-level overview of both Title 25 and Title VII, noting, and with an apology to the committee, a lot of you are knowledgeable of these systems and work with your local and county stakeholders on various issues related to it. So hopefully it wasn't too offensive how high level this was, but as always, as someone who's been working in this system for many, many years, more than happy to dig into the detail with you all individually or provide additional context in the days, weeks, and months to come.
Okay, questions for the department? Stephan, I was wondering, seeing as we have a little bit of time yet, could you say a few words about the designated hospitals, what that means, what they're providing, how they get paid, that sort of thing?
Absolutely, Madam Chairman. So when you hear the term designated hospital, it essentially refers to when we have a civil commitment that happens, an involuntary hospitalization in a community, and the state hospital does not have an open bed. So think back to that wait list. Then what we do and what we're governed to do, both by statute and by policy, is to have that individual held and treated in as appropriate of a facility as we can find within the state. So a designated hospital essentially handles that overflow on behalf of the Department of Health. So you can think of facilities like Wyoming Behavioral Institute or WBI in Casper. Cheyenne Regional here in the southeast part of the state has psychiatric beds. Ivinson Memorial in Laramie has psychiatric beds. I believe there's a few in Campbell County. It kind of depends on where the resource is available. So that's what we refer to as a designated hospital, where an individual can not only be held, but can be provided psychiatric treatment while they await admission to the state hospital, or be stabilized and treated to an extent in that designated facility that they could discharge before going to the state hospital. In addition, Madam Chairman, when there isn't that type of resource in a community, or when those designated hospitals are full, then we do have Title 25 patients that are unfortunately sometimes held in emergency departments around the state. So I always think of smaller hospitals, North Bighorn, for example, where a patient presents with acute psychiatric symptoms, a Title 25 hearing process is conducted, a commitment is issued, but there's no beds open. And that's a struggle. It's a real struggle that we have in our state. And that's, the Department of Health will reimburse for those services a little bit differently. So we'll pay for the outpatient observation while someone's being held in an ER or a hospital that doesn't have psychiatric services. We will pay for medication administration and various types of professional services. But those designated facilities like WBI, those other hospitals that I mentioned that have psychiatric services, we will pay generally a per diem for that psychiatric service, in addition to other professional services, like physician fees or the like. So that's kind of how we pay for designated hospitals, and for lack of a better term, the overflow in Title 25. And not to sound like a broken record, Madam Chairman, but that's really what makes the effort with the new facilities so important, is because we want to, as a department, use our fixed costs, our infrastructure at the state hospital as much as we possibly can. We've developed a staffing plan for the new state hospital, and we'll do the same for the Life Resource Center, so that we can basically churn those facilities at the highest volume. Again, not to say that we're just going to be admitting people and kicking them out. That's not the idea. But to really hit our mission as an acute stabilization facility, so that again, we provide better service to the courts and communities who need that level of care, and we can reduce the the wait period that it takes, both on the Title 25 side and the Title 7 side, by nature of improving our physical plant, really hitting our statutorily defined missions from that task force that created them. And again, a really good opportunity that I don't want to overpromise and underdeliver, but we're really optimistic here in the department that over the coming months and years, we can dramatically improve that system to reduce our reliance on designated hospitals and really improve that wait list.
So one other question, kind of from the community point of view. I know many community hospitals, I mean CRMC, but I toured Rollins some years ago, the hospital there, have to really have psychiatric rooms in their emergency department. Do you have a sense of what % of patients who are in the emergency room, maybe even at 24 hours or so, for psychiatric problems, what % of those folks end up being committed? In other words, the Title 25 commitment is really sort of a tip of an iceberg, which is psychiatric patients going into the ER. And I'm just wondering, how big is the tip? A third of the patients go on. I mean, and I suppose it varies by county, what the county attorneys, what the people think, what the law enforcement does. I mean, I realize that would be variable, but do you have any numbers on that?
Madam Chairman, it's a wonderful question. I wish I had a better answer. To put it very generally, without a whole bunch of data to support it, we know that the majority of folks who begin in the Title 25 commitment process do not reach that culmination of, a civil commitment to the state hospital. They're discharged or stabilized, or the attorney or the mental health evaluator determines that it's not, dangerous to self or others, and so the process stops. We don't have a really good figure of what that percentage is, because in that first 72 hours, we don't have a unified, data source. The state doesn't really control that. We've had conversations with various counties in the past about, is that a role that the state should just take over that process? And it comes with benefits and bugs, where I think a lot of counties might appreciate that, but also at the same time, state takeover, for lack of a better term. I think there's some reticent feelings there too, about having the state in a fully controlling position of Title 25, but it really does limit our ability to know exactly what's happening statewide in those first 72 hours. For example, the number of emergency detentions that happen, the number of continued detentions that happen, and therefore how many of those do not result in involuntary hospitalizations. We have some data on that, Madam Chairman, and I would say it's better in some counties than others that share that with us, and happy to produce that, but with a huge caveat that it's not really unified.
Okay. Okay, any last questions? And just thinking back, because this is the end of Department of Health for today, so we may not hear from them later. Representative Flitner.
Thank you, Madam Chairman. I did have a question. If a Wyoming resident were detained in another state, I know that Representative Connolly had asked for comparison data with other states, but say, for instance, if that were to happen, or conversely, a non-resident were to be detained in Wyoming, could a family member request that say, for instance, if it was my son who is detained in another state and I felt he would have better care in Wyoming, would I have the opportunity to try to bring him to this state for care here if he could get into a facility, and vice versa?
Madam Chairman, Representative Flintner, it's a great question, and the very overly simplified answer is yes. We are part of an interstate compact on mental health, really kind of in our region that kind of governs some of that, sharing of patients, for lack of a better term, or those types of appropriate transfers. So there is a process for that. In addition, kind of less formally, I would say, in other states' civil commitment processes, including and Wyoming's, which I'm very familiar with and have worked with our bordering states on a number of these cases, kind of informally that process can work as well, where if a Wyoming resident is in Utah, for example, and civilly committed, often those facilities will be in contact with parents, guardians, supports that are back home, or with facilities in another state if the person's residence was in Wyoming, for example, but they were traveling or working in another state. We do see that happen quite frequently. So there's kind of a formal process for it when it comes to kind of the interstate exchange of patients. And happy to provide you some information offline on that. But then informally, I think there certainly is a way to do that. I would say if there are, in certain cases where it's kind of a gray area between a civil and a forensic commitment, so maybe there's a criminal charge or an arrest, but it's clearly a behavioral health acute crisis, that situation can get a little bit more muddied if there's, if the legal system is involved in that way in another state where jurisdiction really does come into play.
Thank you.
Do I see any more hands? Okay, then I will point, Representative Connolly, is your hand up? Oh, you're on mute.
Thank you, Madam Chairman. And I know this wasn't part of our presentation, but I am curious if the department has slides that's related to what Medicaid expansion would look like in our state that perhaps they've already done for the Revenue Committee. And if we could get a copy of that so that we can kind of look at that in relationship to what we just learned in terms of what their current services are. Thanks.
Madam Chairman, Representative Connolly, absolutely. I think LSO certainly has our presentation from this week for the Revenue Committee, but we're more than happy to forward that. I will say at the outset, while there's some information that would be related to kind of the behavioral health issue, that information isn't fully outlined in that presentation, but happy to have conversations about what Medicaid expansion would mean demographically for that type of population, as well as how it would interact on the funding side with current state programs that provide, for example, mental health services, and what expansion would mean in relation to that.
Representative Romero Martinez.
Thank you, Madam Chair. 2 points. One is a question. Well, actually, one is just a comment related to one of the previous comments from the department, and a good member mentioned if you have any questions in regards to, and of course we've been talking about an entire encyclopedia of thought here, to please reach out to you. This is my reach out. So even concluding this meeting, if I can have some members of your group reach out to me, I would like to talk to you about some of the areas we've already discussed so far. And then the second point is I spent some time in my district yesterday, and this is a question. And the question is, can we do better as state legislators to work with our cities and counties? Not that we're not doing that already, but for example, in my district, there is an area where there is a concentration of people that would fall into both 25 and Title 25 and 7. And you have a park, you have Martin Luther King Park. I'm just gonna, you know the area, you have Camilla Shelter, and you have this high volume of, I'm just gonna call them what we call them in the 80s or the 90s, streetwalkers. And they need help, but they fell through the donut hole maybe because of 2016 and however code was being attempted at that time, and these gaps that we're seeing. What can we do there? I guess, are we doing enough? Can we do more? Can we use, Zoom meetings to do that? I know that I don't want to belabor the issue. I think you guys get the point. Thank you, Madam Chair.
And just following on that, there under Governor Meade, there was some sort of a homeless initiative that DFS was working on. Is that still existing? Because I mean, I'm not saying all of that population is homeless, but there's a lot of overlap.
Madam Chairman, I was familiar with Governor Meade's initiative. I believe a similar initiative is still ongoing with Governor Gordon's office, but don't quote me on that. I certainly don't want to speak for them. Representative Romero Martinez, to your question about what's the best way to increase either services or improve outcomes for the type of population you mentioned. I hate to sound like a broken record, but that really is the fundamental problem that we're trying to deal with in our community behavioral health system, because being set up to provide treatment and social supports is very different from having folks engage or come to get services and social supports, especially kind of the populations you mentioned who might end up in higher levels of care or other systems. That's exactly what we're working with a few of the members of this committee and others in our kind of effort with House Enrolled Act 56 to design that and define what the role of providers in more of these social contexts should be, both in the Title 25, Title 7, corrections, and high needs, families and kids context. So I know it's kind of an initial answer, not trying to tap dance around it bureaucratically, but more than happy to communicate with you on how that work is progressing during this interim period with those folks.
And Chairwoman Wilson, also what the governor has done is created what's a mini cabinet, but it's Health and Human Services. So it includes Department of Correction, Family Services, Workforce Services, and Health. And we're meeting on a regular basis for those very types of questions. So I think any of us in that can advance those issues to talk about how we can work better together to do that.
Okay, any last questions? Okay, I will point out, committee, that I see that Katie Talbot has sent out the slide deck for this afternoon's presentation by DFS. So if you check your inbox, that'll be there. And we will recess for lunch and be back at 1 o'clock. Thank you.